Hello, everyone. If you want to go ahead and get seated. There you go.
Buenos días. Good morning. I'm Dr. Mora, and soy la doctora Mora. Me gustaría indicarles que hay traducción al español simultáneamente, that we are providing Spanish translation simultaneous. Acá está el equipo. The equipment is over here. If anybody, las personas que necesiten traducción o corran la palabra, or please spread the word out. Thank you.
Okay, right now we're going to go ahead and start with the presentation of colors and go ahead and get started. Thank you.
Oh, say, can you see by the dawn's early light what so proudly we hailed at the twilight's glass gleaming, whose broad stripes and bright stars through the perilous fight for the ramparts we've watched were so gallantly streaming, and the rocket's red glare, the bombs bursting in, gave proof through the night that our flag was still there. Oh, say does that star-spangled banner yet wave for the land of the free and the home of the brave?
Great job. Thank you, everyone. Go ahead and have a seat. So we're going to go ahead and get started here, and I have a few announcements. First of all, if you'll all look in your blue bag that you should have received when you came in, there is a folder in that bag, and if you can take a look at that, I'll go over what's contained in there. So in the folder on the left-hand side, the first thing you should see is an agenda, and we will be trying to follow that as best we can. After that is a biography of our speakers that are coming in today. And then finally on the left-hand side is an evaluation form, which will ask everyone to fill out and turn in before you leave. And that's essential to see how we perform each year. And then on the right side of your folder, there is a recipe here. And this is what we will be cooking during our cooking demonstration, which will be coming up soon. Then we have an example of 15-gram carbohydrate servings, and that should be the next page. Followed by that, in English and Spanish, is a patient preparedness plan, a glossary of terms that we sometimes use here. So a lot of our presenters are medical, and so if they use a term that you may not understand, it might be in that glossary of terms that you'll see. Also, to let you know, outside, we have a van there, and Blue Cross Blue Shield is going to be doing foot screening. And they also have blood glucose screening, diabetic screening, A1C screening, blood pressure screening, pulse oxygen and BMI screening. So if there's anything you want to be screened for, we probably can do it out there. In addition to that, we have outside, which we can see during breaks, we have our vendors, and I encourage everyone to go in and see our vendors and see what they're offering this year. We also will have a vision screening a little bit later on, which will be provided by the Las Cruces Host Lions Club. And we do have snacks outside and a break room if you want to use that as well. So please take advantage of that when you can. So our first speaker, Melinda Guerrero, is ill and is not here today. So I'm going to be doing a little bit of some drawings. So everybody who got a blue ticket, I'm going to go through those and we're going to see if we can get you one of our door prizes to start here. So all of you, if you'll take a look at your blue tickets. So I am going to read this and I want you to look at your blue tickets to see if you're the lucky winner today. So our first door prize is 919450. Okay, we have a winner. I'm going to put you to use here. Can you give our winner? So what we do have is we have some car window screening. And since you are our first winner, you will get the first screen. And so our next ticket here is 919449. Anybody have number 49? No lucky winner yet. Okay. We do got it. Okay. And so our next ticket that we have here is 919454. Anybody have number 54? We have number 54. We have a winner. And surprisingly enough, we have another ticket. And this ticket is 919453. Right next to the last winner, we have another one. I'm going to do one more for right now, but keep your tickets. If you haven't won, you'll probably win later on. And we have 919455. Does anybody have number 55? The young man over here has number 55. In green. So we're going to be starting a little bit earlier with our cooking demo, and that should be starting fairly soon. So as soon as we're ready to go with that, I will let you know. If you have any questions, you can ask me. Our good helper, Bob, over here to my right, to your left, will be helping as well. Anybody from the Burrell College of Medicine can probably help you as well. And we're going to get started here and be back on track in just a little bit with the cooking demo, which should start soon. And so just enjoy yourselves. Go ahead and talk, and we'll be with you real soon here. So thank you.
Welcome.
That's fantastic. Okay. Let me go as soon as you're ready, and I'll go get you guys introduced, okay? Yes, by all means. please. No, but I have to run the lunch. There can. Are you with the solid with Pharrell or are you with?
I'm just gonna do half and half on camera. Why don't you just stand right here? Just be right here. Or right here. Okay, what do you mean feel it? Oh, how do I? I'm pretty much, I don't ever. Get the, and I'll start with the stuff about, and I'll also pass. welcome to use this. Okay, and so I'll kind of just point to it. Do you like public speaking, right? It's different, yeah, it's different. I've struggled with that like my whole life. I don't know, I don't consider this like, cause I know what I'm talking about. But once I start getting there, that's why I have all my questions. Yeah, just so look down, down. Once my mic goes blank, I'm like, like to do these. That way I'm only putting the two on camera. Did you need this?
Only when you're ready.
I think
It looks like you're still chopping and
no. Well, she's gonna chop as we go. She was just getting rid of some of the.
I see no loose fingers or anything, so that's good. Okay, so I'll go ahead and get everybody started here. Okay, everyone, we're going to go ahead and get started again. We're getting ready to do our cooking demonstration, and we have 3 people who will be introducing themselves in a second and showing you how to make a 10-course meal. Oh, wait, sorry, it'll be the actual recipe that's in your folder. And so with that, let me go ahead and I'll pass this over. You guys can introduce yourselves and let them know what you're doing today.
Thank you. And welcome, everyone. We are from the New Mexico State University Dietetic Interns. We have Jenna, who's our camera person today. She'll be spotlighting so you all can see Sadie, our second intern, will be doing the demonstration of the Cuban salad. And my name is Marisa. And we want to thank the ICANN program for lending us some of their
And make sure you
equipment.
speak a little louder because of the mask.
Okay, so thank you all for being here. Again, we're the NMSU Dietetic Interns. We have Jenna running our camera, and Sadie will be doing the demonstration of cooking this simple, easy recipe that you all have in your packets. We wanted to thank the ICANN program for lending us some of the equipment because we did prepare this recipe that after we're done here, you'll all go out there and be able to sample it along with the dressing. So it's the Cuban salad, and the Cuban salad, the ingredients for the salad dressing are going to be 3 tablespoons of vegetable oil. And it can be also your choice of oil, but this is the one that the recipe is using because it's a good combination with the lemon. So it's got a 1/4 cup of fresh lemon juice, which is about 2 ounces, or you can use fresh lemons, a teaspoon of garlic, which is about a clove or 2 of fresh garlic, or you can use garlic in a can as long as it's in water because you're already using oil. It's going to have a 1/4 teaspoon of salt, a 1/4 teaspoon of black pepper, and fresh pepper is really good. So for those of you that want to use fresh, and it's going to use a head of romaine lettuce, washed and patted dry, and 2 large tomatoes diced, 1 red onion, finely diced, and 6 to 8 radishes. So what we did is we started out with making sure that everything was properly washed. First, you always want to make sure you wash your produce because when they're transporting it and people handling it. And of course, when you're doing your selection at the store, you want to make sure that you get home and before you are going to use it, you wash it well. The lettuce, especially because romaine lettuce tends to be one of our lettuces that along the middle has a lot of sand and just how it's grown. So what you want to do is you just want to tear it apart into pieces after it's washed and pat it dry with a paper towel. For those of you that have kids, this is perfect because you can start incorporating some simple kitchen activities with them as they're able to help you kind of cut the lettuce apart. And you can use any type of lettuce, but the romaine green is nice. It's a good way for you to get more of your vegetables. There's 95% of women in general don't get enough dietary fiber, and men it's about 97%. So this is definitely a way for you all to incorporate more fiber in your diet. So then we're gonna do it's gonna include a tomato. So Sadie's gonna dice half a tomato, and we already have the other half sliced. And with a tomato, for when we're preparing for a big group, it's a little harder to get rid of the seeds. But for presentation, typically with tomatoes, you want to try to get rid of them so that the salad looks a little more appealing, and it's not as liquidy when you put it in and mix it in with a salad. Yeah, and you can use any type of tomato. I know I like little cherry tomatoes. You can always cut those in quarters and have them in bigger pieces for presentation as well. And it does ask for 1 full purple onion. The onions are not as strong as white onions. White onions you tend to use more for grilling or for frying, like onion rings and things like that. And so the purple onion tends to have a sweeter flavor, and it does look pretty when it comes to presentation for this Cuban salad as well. And some of the research that I did, according to one of the studies, 52% of adults don't really know how to, we always talk about, as dietitians talk about ways to increase your fiber and increase your vegetable intake. And a lot of adults, 52%, almost half, don't know how they can increase it. And so just having a salad made already in your fridge is one way. That way you can just add it to a side dish that you are going to prepare. You can add mixed greens or a salad like on sandwiches, just to increase the variety of foods that you want to have. So we always talk about the rainbow, every vegetable and tomatoes, they all have different vitamins and minerals. So you definitely want to try to have a variety of those foods. So now we also have radishes. The salad calls for radishes, and they're just, again, most of it is for presentation, that you want to have them sliced thin, but have them pretty much in whole circles. And then it's also going to have some garlic. And the garlic we're going to start putting in a clear little bowl, because that's going to be part of our salad dressing. We've got a clove of garlic. We're gonna do 2 ounces of lime juice. And of course, if you have fresh lime juice or lemons, is better. You know, it takes about a couple of small ones, freshly squeezed. And this is 2 ounces, which is 1/4 of a cup. So it's about half of one of these little bottles. And it's gonna have 3 tablespoons of oil, which we pre-did. And the reason we wanted to do that is because this is a container that you can reuse if you wanted to make the salad dressing to have in your refrigerator for later use, because the recipe calls for adding the salad dressing right before you eat the salad. So it's nice and fresh. And then we're gonna add the salt and the pepper. And that's just 1/4 of a teaspoon. And then we're going to mix it up nicely. And all of you will be getting the little salad dressing in separate containers, so that way you can all add it to your salad. And what's nice about this bowl is that you can, you want to go ahead and pour it in there? Is it has a lid. So a lot of times it's really nice and convenient for you all to be using that as just a mixing. Again, when you have kids, you can always have them be the ones to do the shaking of the bowl. So do you all, how many of you think you're gonna really like this? How many of you have ever had this? Okay, couple of you. Okay. So this is a perfect salad. It goes really good with fish like canned tuna, sardine, or salmon. You know, if you wanted to add any type of protein, you can add some nuts. I know that nuts, we do have some as a snack out here today. Or for people who like some type of cheese, you can always add that as well. And it's a simple, it's not very expensive, it's very few ingredients. A lot of the times you already have some of this at home. There are items that are already available to you. So I hope you all enjoy this Cuban salad. Thank you.
So thank you so much for that. And I want to let all of you know, we're going to take a break in just a second, and we have our Cuban salads outside, and we encourage everyone to go ahead and get a sample of it and try it out and see what you think. During our break, we do have our vendors rooms, which are out to my right, your left, and down the hall. And I encourage all of you to go see our vendors and visit them and see what they're showing off this year. And so we'll go ahead and take a small break at this period of time, and we'll be back in about 15 minutes. So thank you so much, and go out and see everyone, okay?
and these guys.
Okay, we're going to go ahead and get started again. And before we start with our next speaker, we have some more drawings. So those of you who have your lucky blue tickets, we're going to start off with 919457. Does anybody have number 57? No one is looking hopeful for 57. So how about this 919456? We do have 56. Okay. And next we have 919461. Anybody have number 61? And willing to admit it? No. We have 919445. Okay. And we have 919459. Anybody with number 59? Yep. And we have 919452. Anybody with 52? We have 52. And last for right now, we have 919446. Anybody with 46? Yay. Okay, so we're going to go ahead and get started with our next speaker. And our next speaker is Dr. Robert Greyer, and he'll be talking about diabetes and heart disease. And so Dr. Greyer, if you want to come on up. Here you go, sir. Thank you.
Thank you very much. We don't need this on what we talk, do we? Okay. Good morning. I'm going to try to do an overview of the relationship between diabetes and heart disease. And we're going to need to go through a couple slides of definitions because heart disease is a fairly broad category and its relationship to diabetes gets even more complicated when we begin to look at some of the causes of diabetes causing heart disease. Just a little background on myself. I'm an interventional cardiologist. I trained in, I went to University of Chicago Medical School, then did my training at Cleveland Clinic and spent 25 years there, and then came to Las Cruces to private practice, and have enjoyed every minute that I've been here. My training was in internal medicine first, then that's followed by cardiology. But before I went into cardiology, I did a fellowship in vascular medicine, dealing with the arteries outside the heart, and a year of fellowship in vascular surgery, and then 3 years of fellowship in cardiology, and became an interventional cardiologist where we actually do the surgery on the coronary arteries. So with that said, you all probably know that heart disease is the #1 cause of death in both women and men in the United States, and it's actually the #1 cause of death around the world. If you have diabetes, you are twice as likely to have heart disease or stroke than somebody who does not have diabetes. And we'll get to the underlying reasons for that. We'll get a little further into the talk. And they're quite complex. Years ago, when I was in medical school, it was much easier to draw the relationship between diabetes and heart disease because we didn't know anything about it. We didn't know that relationship. Now that relationship has gotten quite complicated, and it'll take some time. What you all want to try to avoid is this scenario where you end up on a cart going to a hospital with chest pain with an evolving heart attack. And the purpose of what we're going to talk about is to try to prevent that, to try to reduce the risk that you end up in that position. So let's deal with the definition. What is heart disease? It's cardiovascular disease. Cardiovascular disease the most common type of cardiovascular disease is coronary artery disease, where the arteries in the heart get build up with plaque, and that buildup of plaque reduces the ability to deliver oxygen and the nutrient supply to the heart muscle, and eventually can lead to obstruction of the coronary artery and a heart attack. Plaque is a buildup of cholesterol, commonly known as cholesterol, but it's a bunch of stuff in the artery. It's a bunch of moieties that make up the plaque. It's not just cholesterol, it's other cells, foam cells, fibrous cells, and many other things. It's commonly known as hardening of the arteries. We call it atherosclerosis. Now, decreased blood flow to the heart can cause a heart attack. We call that myocardial infarction. And then hardening of the arteries, arteriosclerotic disease or atherosclerosis, can occur elsewhere in the body. And that's another problem that diabetics run into from time to time. That is obstruction of the arteries going to the lower extremities and obstruction of the arteries going to the brain. So what does that look like? If this is a heart, of course, this is a coronary artery, happens to be the left anterior descending coronary artery. The left anterior descending coronary artery is down the front side of your heart, goes from the aorta, where it originates, down to the apex of the heart being down here. When you have obstruction in that artery, plaque builds up, narrows the artery, and then ultimately that plaque buildup can lead to such a severe obstruction that the artery then clots. So the final common denominator in a heart attack is usually thrombus or clot that occurs over a plaque. These plaques, this is the atherosclerotic disease that we referred to. The way we approach this, and this is something that's really, for the medical students in the room, this is something that just recently occurred in the late 70s, early 80s, where the final common denominator of a heart attack was clot. So we realized, well, if we give these people blood thinners and we reduce that clot burden, maybe we can restore flow back through that artery. And that led to the development of all kinds of medications that help us get through that clot. And then we have to do something about the artery or it's going to reclot. So we have agents that help us with that. And now we've developed instruments that we can put in the artery, open up that artery, reduce the plaque burden, and reestablish flow and stop the damage that's being done to the heart, commonly known as stents. This is a coronary arteriogram, and wanted to just show you what it looks like to have some plaque in your artery. This is the right coronary artery. A right coronary artery, if you look at the black line here, this is the actual inside diameter of the artery. And it's filled with contrast that we've injected into that artery through this little tube that's up here. So we've actually cannulated the origin of this artery with the catheter. We inject contrast and we see the outline, the inner lining of the artery itself. Now, arteries should go from big to small and they should be smooth. They shouldn't be obstructed. If you look over on this side, when you see the smooth, relatively smooth artery going down through here, that's what they should look like. If you look at this side, we start big, we get small, we get big, we get small, we get obstructed again here, we're obstructing down here. That's plaque in the artery. That plaque or atherosclerotic disease in the artery is what obstructs the flow, leads to the clot formation in the artery, which leads to the occlusion of the artery, which leads to the heart attack or the myocardial infarction. So why should this all concern us? Well, when we started the talk, we talked about the fact that the #1 killer in the United States is heart disease. And so that's why I think we should be concerned about it. Our job as physicians is to try to extend life, in a fashion that people can function, can have a good life, and not be impaired by congestive heart failure or by what we call an ischemic cardiomyopathy. So again, cardiovascular disease is the most prevalent cause of morbidity or mortality and morbidity in the diabetic population. Morbidity, if you don't know what that is, that's impairment of your life. You know, strokes where you don't die, but you're paralyzed. A weak heart that causes you to have the inability to exercise and so forth. That's morbidity. Mortality, we all know what that is. Death and mortality and death and morbidity are largely due to heart attack and stroke in diabetics. One primary goal of diabetic treatment is to improve the cardiovascular disease risk, lower the risk of obstruction of arteries in the body. Now, a major challenge associated with treating diabetics and reducing cardiovascular events is the fact that it's a complex, multifaceted nature, the relationship between diabetes and cardiovascular disease. It's not a simple equation. It's not, well, if I eat a donut, I'm going to have a heart attack, just that simple. Because I think there's probably some donuts that have been eaten in this group of people over maybe. So it's really complex because, you know, if you think about it, if you talk to your neighbor, neighbors always have the best advice. They always know better than anybody else in town. So you talk to your neighbor and they say, well, you know, I smoked all my life and I didn't get lung cancer. And then somebody says, well, I only smoked one cigarette and I got lung cancer. It's because this world of medicine is not simple. Just because you've got diabetes doesn't mean you're going to die next week from a heart disease. But somebody else you know with diabetes may. And what's the difference? What's the difference between somebody who has a bad outcome versus somebody who seemingly goes through life without major problems? And that's where we don't have all the answers. It's tough to really know for sure why there's such a variability in response to disease. These are platelets. These little flying saucer type items are platelets. In diabetics, there's activation of platelets all the time. Now, what do platelets do? You guys know what platelets do? The medical students? Clotting, right. So when you activate a platelet, they want to stick together. So you cut yourself. What keeps you from bleeding to death is the platelets go rushing to the area that is bleeding or cut and clogs up the hole so that you don't keep bleeding. In an artery that has plaque in it, there's a derangement in the surface that causes some activation of platelets. There's things that we do that cause activation of platelets, and that's what can lead to blocking off an artery ultimately. So we know that diabetes is a major risk factor for the development and progression of coronary disease. We've talked about that. Following a heart attack or an MI or a myocardial infarction, diabetics have higher rates of morbidity and mortality for reinfarction, approaching 50%. So if you're diabetic, you get a heart attack, you race to the emergency room, which is what you're supposed to do, not drive. You're supposed to call an ambulance. We have people that drive and sometimes they make it, sometimes they don't. We get called in, somebody's having a heart attack. We open up the artery, we put a stent in, we do what needs to be done. We do coronary bypass surgery to improve flow through their heart. You still have a much higher risk of blocking off the treatment than somebody who's not diabetic. And some of that is due to some changes that occur in the artery, increased expression of 2B3A receptors in something called von Willebrand factor. You guys know what that is? You got that, good. These are the medical students that I was talking to earlier. These problems cause diabetics to have a higher risk for failure of treatment and also have a higher risk of initiation of failure of an artery. Is that clear? No? So if you have these biochemical things that are happening in your body that are activated in a pathological way, in an abnormal way, you have a much higher risk of developing a disease process, an event, a heart attack, a stroke, or whatever, than somebody who's not diabetic. And it's sometimes just through these clotting activation mechanisms that we end up getting into trouble. We always have to talk about this, fat. Unfortunately, it's a common problem. Unfortunately, it adds to the disease process. And unfortunately, in diabetics, it accelerates everything. I'm not going to go through all the stuff. Whoops. I'm not going to go through all the stuff on this slide because it's really lectures in itself, but obesity creates a syndrome of inflammation, among other things. And it causes situations called insulin resistance, expression of cytokines, tumor necrosis factor alpha, interleukin, leptin, resistin, fibrinogen, angiotensin. These are all sort of biochemical phenomenon that occur in the body that get activated and cause the process of disease. We don't know about these. We don't feel them. We can't touch them. You don't have a label on your body that tells you what they are, but these are things that are functioning in your body that cause some of the problems that we get into. The increase in inflammation and lipid accumulation leads to endothelial dysfunction. What's endothelial dysfunction? Endothelium is the lining of your arteries. It's this velvety structure that is a huge part of our body that has a lot of function. And we don't know anything about them because we can't see them. You can't feel them. You can't test for them. But it's a lining of all your arteries in your body. That endothelial dysfunction leads to heart attacks, cardiomyopathy, blockage of the arteries in the legs, all kinds of disease processes that we have to be concerned about. C-reactive protein impairs endothelial production of nitric oxide and prostacyclin and all these things. Again, these are sort of esoteric things that you don't have to know, but just understand that it's a complex thing that occurs in our body that causes our body to present with failure. And that's what that's all about. Hypertension. 60% of type 2 diabetics have hypertension. That can lead to diabetic kidney disease called nephropathy or nephrotic syndrome. Left untreated, it can lead to higher risk of clotting through loss of antithrombin 3, another process in our body that we can't see, touch, or feel. Dyslipidemias, another complex area of study and treatment. This is your cholesterol levels. And I'll bet if we asked every one of you in the room, what should you worry about with cholesterol? Is it the HDL? Is it the LDL? The VLDL? Huh? All of it? What do you guys say? It's okay. So the medical students say LDL. Is it LDL alone? How does it help? So high HDL doesn't help anybody. So, you know, and when I exist in my practice in the office, it's amazing when people come in and they'll tell you, well, I've got a high HDL, so I don't care what my LDL is, or I don't care what my cholesterol is. I'm protected. No, you're not. You're not protected. ultimately, the risk factor that you have to worry about with all those cholesterol values that they give you when you get your blood drawn is LDL. Okay, now there's LP little a and all these other ones that we have that we can be concerned about. Unfortunately, we don't have treatments for them, so we don't talk much about them in the office. But the only value that you really need to care about on your lipid profile when you go to the lab is your LDL cholesterol. This is an aggressive recommendation, but everybody in this room with or without heart disease ought to have an LDL below 70. If you have heart disease, you better have an LDL below 70. Otherwise, you're at risk of having reoccurrence. Diabetic cardiomyopathy. You know, it wasn't until recent years that we knew what this was. We knew that diabetics frequently would present with heart failure, and they had normal systolic heart function. Systolic heart function is where when your heart beats, it squeezes blood out through your body. That's normal function. If your heart is weak and it can't squeeze much blood, then that's weak heart function or poor systolic function. But what tends to get diabetics in trouble with heart failure more frequently than non-diabetics is something called diastolic heart failure. And diastolic heart failure, so the heart has, in the process of keeping you going, the heart functions with systole, where it contracts and pushes blood out, and then it has to rest and open and fill in order to accumulate blood to push out again. Diastolic heart failure patients don't fill very well. They get a more rigid, less contractile ventricle, and so it doesn't participate in both the systolic and diastolic activity as well as non-diabetic hearts do. Now, some non-diabetics can get diastolic heart failure as well. So what happened is over the years, we were beginning to see heart failure in people with preserved systolic function. They were able to contract and push the blood out normally. Do you realize that your heart beats about 120,000 times a day? 120,000 times a day, every single day. So when you think about that, it's an amazing organ that does this day in and day out, asleep, awake, running, standing, sitting, eating donuts, same thing. It's doing that every single day. Well, you can imagine if you impair some of those cycles, if you begin to impair all those cycles, that could lead to a problem, and that problem is heart failure with preserved systolic function and impaired diastolic function. Non-diabetics get it too, but diabetics get it far more often than non-diabetics. What happens in these patients is that you have an increase in fats in the blood. It affects the calcium and the fat accumulation to the heart. If you reduce triglycerides, and how do you reduce triglycerides? You reduce sugar, alcohol, and fat intake. The effect of calcium in the heart becomes impaired, and fat accumulation in the heart is associated with this diastolic function dysfunction that we've been talking about. So what do we do about all this? Well, you guys know more about this than I do, probably. You know about diet. You've probably been preached to, if you're diabetic, you've been preached to all your life that you have to control your diet. You have to control your body size. You have to control your sugar intake. You have to control alcohol intake and all these types of things. What we're never, at least physicians are never really taught is, how do we do all this stuff? What do we replace this with And how do we get patients to understand that they have to transition from the good old American diet to a diet that maybe will preserve body function and life for them? Tough thing to do. And again, for the medical students in the room, you will battle this the rest of your life. It is very, very difficult to get people to change eating habits. Very difficult to get people to do one of these rather than a donut. Doesn't taste as good as a donut. You know, I mean, it's true. But the difference is huge. I think if we could control diet better, more fruits and vegetables, a much cleaner diet, then I think what we would find is that people are healthier and live a better life. But the world is against us. Industry is against us. If you watch TV, you see all kinds of ads for things that we shouldn't eat. You know, I got this coffee cup at home that says the cardiologist diet is if it tastes good, spit it out. You know, it's true. The stuff that we like is probably not that good for us. The stuff that we like, we could probably do in moderation, but we tend to occupy our entire life with the stuff that's probably not so good for us. And this is not only a slam on diabetics. This is a slam on all of America, actually around the world. If anybody has a way to control this, boy, step forward, because I think you might make an impact on life in the United States. I'm going to put one plug in this talk. I don't generally like to do that because I think it's wrong, but you know that there are food guidelines for fruits and vegetables on a daily basis. What your daily requirement or your daily amount should be. And it's virtually impossible for any of us to achieve those daily requirements, no matter how hard you try. First of all, to go out and get all these servings of vegetables, fruits and vegetables every day would make you broke. It's expensive. You know, it's not an easy way to go. So we have to supplement things. We have to go to some method by which we can achieve these daily requirements and yet not break the bank. And one method of doing that is these fruit and vegetable tablets or capsules that are being advertised. In our office, we recommend Juice Plus. There are other brands on the market. I think there's one out of Texas someplace. You're from Texas. What's the name? Anyhow, it's freeze dried organic fruits and vegetables in a capsule. It's easy to get. It's easy to take. It's very nutritional. And it provides you with what you should have been taking, what you should have been eating every day of your life. So it's probably better than taking Centrum, one-a-day vitamins, some of the other junk that's out there on the market that really never gets absorbed and utilized by our body. So that's the one plug I'm going to do. It has to do with these organic fruits and vegetables that are in a capsule, and I think it'll take you to a different level of care. I think this is the last slide, maybe. I'm not an endocrinologist, and I'm not an internist that takes care of diabetics every day. Typically, cardiologists do not handle the primary care of diabetics. Typically, we handle the problems that you guys get into, but we don't handle the everyday care of them. There's lots of medications on the market. And I want to talk specifically about two classes, the SGLT2s and the GLP1s. These are two relatively new medications that have hit the market. The name brands are up here on the screen. They work differently, but they really have changed the landscape of how I think diabetics should be treated. The big problem we have with having you take these medications is that they're expensive. And it's very frustrating that if you lived in, another country, you could probably buy these pretty cheap. But if you live in the United States, you pay more than anybody else. But Farxiga and Jardiance and Trulicity and Victoza and all these medications that are available really get to some of the physiology that's going on in our bodies that will help us be able to get healthier. The SGLT2s are sodium glucose cotransporter inhibitors. What it does is it prevents the reuptake of glucose. Typically, people on these medications lose weight. They diurese better, they get rid of fluid better, and their blood sugars are better. These medications are generally used in conjunction with other basic medications that you're on for your diabetes. And that's it. Questions, comments, arguments? Yes, sir. How to lower LDL? Diet. We'll lower it a little. If you go on a diet that's low in cholesterol, your LDL is going to lower probably somewhere around 10%, maybe a little bit less. That's about the best you can expect. It's not very much. So if you've got an LDL of, 120, you're lucky if you get down to 100 with that. Okay. I already told you you need to be 70. So you're not going to make it on diet alone. That's the reality of the situation. Statins, atorvastatin, simvastatin, all the statin drugs will lower your cholesterol pretty darn good. If you can't take a statin, there's these relatively new class of drugs called PCSK9 drugs that are injectable once or twice a month, and they lower cholesterol, LDL cholesterol, very dramatically. As a takeoff from that question, there was years and years ago, there was a guy who wrote a book called Reversal Trial. Caldwell Esselstyn wrote that book, and Caldwell Esselstyn was a general surgeon at the Cleveland Clinic, and he did a trial where he took people that had known coronary disease and had known abnormal lipid profiles. And he took a select group that he was able to actually cause these people to almost go out and graze in the backyard for their food. It was really amazing that he was able to capture this group of people that were compliant doing that. And he lowered their LDL cholesterol to way below 70, like 40 sometimes, 30 sometimes. And what we did a heart catheterization on these people before they started the trial. And we did a heart catheterization at 1 year and 2 years post grazing in the backyard. And what we found, we did quantitative coronary angiography where you actually measure plaque with a computer. What we found is that about a third of the people had progressive coronary disease despite the diet change. A third of the people had really no change or no significant change. And about 30% of another third of the group had regression of coronary disease. And that's how that book got published. It was a regression or taking away of obstructive coronary disease. In actuality, what we've learned since then is it wasn't really the plaque regression that occurred. What occurred was what? No. It was clot formation that was on the plaque that didn't form. So initially we thought, oh, so that just really invalidated that trial completely. But the important thing that we learned from that trial was that if you do lower LDL cholesterol, however you're doing it, you reduce that risk of clotting. If you go back to what we talked about in the beginning, clotting is the final common denominator that results in a heart attack or loss of a leg or stroke. It's clot that finally produces those bad outcomes. So I think unfortunately what you're left with, unless you want to graze in the backyard, you're going to have to take a statin or a PCSK9 drug. Yes. Another pill. So there are a lot of issues that you can reduce risk by taking a pill. And is it something like, you don't have a name of it. The ACE inhibitors and the angiotensin receptor blockers tend to improve heart and kidney disease in diabetics. Yeah, yeah. So it's probably a good idea. If you've got advanced kidney failure, then you got to be careful with those medications. Any other questions? Yeah. There you go. Yes. Yeah, they recommend you take them at night. Mhm. Did you have insomnia before you took them at night? You can take it in the morning. Why do you have to take it at night, you know? Yeah, I know, and I don't know the answer to that, actually. It came out about, geez, I don't know, it had to be 15, 20 years ago, where it was more effective if you took it in the evening, maybe because there were some foods that were inactivating it during the daytime, maybe. That data is very, very weak. So if it's keeping you up, take it in the morning. Any other questions? Well, thanks a lot. And you know, I wish you all the best of luck. I think some of the things that we talked about are really, really tough to do. And you know, I have great sympathy for people who have diabetes because they have a difficult life and it's not easy to get along with these problems. Type 1, type 2 doesn't matter. I think it's tough. And but the best you can do is the best you can do, and keep trying, because it will have an impact. Watching your weight, reducing excess calories, eating the right food, supplementing appropriately, I think is really, really important. So try to do it. It doesn't pay you a dividend from Monday to Tuesday. It's from Monday this year to Monday 5 years from now. That's the focus that you have to have. And it will make an impact. Uh-oh, here comes a tough question from the medical school. Exercise and diet exercise alone. There's a couple things we didn't talk about. One was smoking and one was exercise. We all understand diet. Exercise is very, very important. And the Olympic Training Center up in Colorado Springs has done a boatload of studies about this. And they've done some really good investigational work on patients who have heart disease and diabetes, and non-diabetic, non-heart disease patients. And they've looked at long-term outcomes from exercise trials. And, you know, this is at the Olympic Center. So, you know, right away you think, okay, you got to be an Olympic to do these exercises. No, this is standard medical research on people that have problems, and maybe can't go out and walk more than a block or a half a block or 2 blocks or something like that. What they found is that you can get an overall reduction in cardiovascular events, reduction in blood pressure by participating in 20 minutes of exercise a day. And that 20 minutes of exercise a day should be walking. They've done all kinds of other trials, and it's hard to beat walking 20 minutes a day in terms of getting a cardiovascular benefit. Biking is close to that. Swimming is close to that. Weightlifting, running, those don't make any additional benefit. For diabetes, cure for diabetes? Well, I think that there's a lot of research going on in that area. And I think that probably from what we're seeing in the medical literature, probably in the next 5 to 10 years, there may be some major advances in this treatment. A lot of it has to do with stimulating endogenous insulin. A lot of it has to do with getting rid of excess glucose, like the 2 drugs that we talked about, the SGLT2s and GLP-1s. I think you'll find that you'll start seeing this stuff start creeping out. These are 2 major advances in the treatment of diabetes. If we could only get them available for people at a cost that's not prohibitive, I think that's going to make a big difference. In the past, they've tried islet cell transplants, pancreatic transplants, all kinds of things with some good results, not such good results. And I think that's going to get improved upon. Surgical treatment of diabetes may be an arm of the future that may work. So, they've made some huge strides in cancer, yet they haven't made such great strides in diabetes. I think that there are people really working hard at that, though. Yes. It's a hard thing to quantify. That's the problem with it. Stress is probably not good. But to quantify stress is very difficult because you can't measure it. You can't draw a blood sample and measure it. You can't put a blood pressure cuff on an arm and measure stress. I mean, that's the problem. It's sort of one of those things you can't quite grab onto. I'm not sure I have a better answer for you than that. Do you guys know anything more about that than I do? Increased cortisol levels that occur with it, that plays a role in disease process. But good question, but bad answer. I don't have an answer for you. Thank you.
So I'm going to go ahead and do a little bit more drawings here while we get our next speaker. Okay. So we're going to go ahead and do some drawings. So those of you who have not yet won or have stolen someone else's ticket, can you take a look at your blue tickets? And we have 919444. Does anybody have 44? We have a winner here. Yay. And we have 919448. We have another winner. And we have 919463. Anybody have number 63? We have number 63 over here. Huh? Those med students, you'll be having an exam on this on Monday, so I hope you took good notes. Next one is 919462. Ah, we have a winner. So momentarily, we'll be starting with our next speaker who'll be in just a minute. So I'm going to do one more ticket here. So we have 919447. 47 right in the front row. Okay, so we are ready for our next speaker, and we have Dr. Baker here. And so if we can have a nice round of applause for Dr. Baker. And I am going to turn over the microphone to you. And this young lady is in charge of everything else.
Perfect. Thank you. Good morning, and I apologize. I have suffered a cold for the last 10 days, so I have a little bit of a gravelly voice, and I'm going to take my mask off so you can at least see that I have lips. In this day and age, we're never sure if we have those, you know. I'm a family practitioner here in Las Cruces, New Mexico, and have been in practice for 40 and a half years. So, and basically what they've asked me to talk about is kind of, you know, how you ought to prepare yourself when you come to the physician's office. And I titled this my keys to the perfect office visit, but there's never a perfect office visit because something never goes right. I've asked him to pass out some paperwork. I don't have any presentation to put on the screen, and I apologize. That was because I've been under the weather this week. So one of the things that's really important when you first make an office call, if you've never seen the physician, and even if you have seen the doctor, you want to when you make that call to the office, and hopefully you don't get the PAC system that I have to live with. I apologize. I'm whining. Anyway, you let the office staff basically kind of a basic why you need to see the physician. Now, it doesn't have to be in depth. You don't have to give them your whole medical history. It's just because we need to know kind of how we need to judge our time. You know, is it that you just have a sore throat? Or are you having chest pain? Or are you having something different? Depends on what we need to see you for. Depends on kind of what we need to talk about on our time limits. And because we do have some time constraints, unfortunately. Usually recommend to show up 15 minutes early to an appointment because there's always paperwork to fill out, which is as much as a headache to you as it is to us, but we still have to do those things. Bring your current ID and insurance card, because we have to identify you and also do billing information. Again, if this is the first time to the office, you also want to bring contact information. So we make sure that that's current. If it is, you've been there frequently to the physician, like some of my patients who have been there for the last 40 years, want to make sure that you have current contact information, because, you know, we've gone from landline phones to cell phones and to emails, to Twitter accounts, to whatever. So it's helpful if we have some way that we can contact you in a reasonably period of time to talk about lab results or other information that we need to do. Try to bring a list of all your medications. Better yet, bring your medications. Then we can go over them, make sure that we know exactly how you're taking them, how often you're taking them, and really talk about to you all what they're really for. You know, is it for your cholesterol? Is it for your diabetes? Is it for your hypertension? And because it's not uncommon that I will still have patients that will call my office and they'll say, I need a refill on my little blue pill. There's a lot of little blue pills. And better is when they say the little white pill, because there's a lot of white pills. And what's it do? Well, Dr. Baker knows what it's for. Okay, great. So we have to sort through that information. So it's helpful if you understand what the meds are for. Try to bring a list of your concerns every time you come to the visit. Now, is it just because you're following up on your diabetes? Is it just because you're following up for your hypertension? Or is it, hey, I've got left flank pain today and I've got blood in my urine, and what do you think's going on? So give us a kind of a heads up. What's always interesting about being a physician and talking to patients is that a lot of times we'll ask you questions about your health. How have you been doing? How's your exercise? Have you had chest pain? Have you had a cold like I've had? All those sorts of things. And we'll get all these answers. And at the end of the office visit, the patient says, oh, by the way, my right knee hurts. And that's what they came to see me for originally. That wasn't even listed on the intake chart. So a lot of times the, oh, by the way, is the most important thing. So it helps if we got that taken care of ahead of time, but it doesn't always happen. I wish it did. Bring something to write on. Usually I'll have a pencil and a pad or a pen and a pad and write things for patients. But, you know, if it helps if you all will write things down, if you get your answers and say, oh, he said this, or oh, he said that, or if there's an adjustment on your medication, say we've raised your blood pressure medication, or we've increased your amount of insulin, or even changed you to one of the newer longer acting insulins, let's say, or the new glutides that are out on the market for diabetes. So those sorts of things. Bring your vaccination at the first visits that you see a physician. Bring your vaccination information. That's helpful because this day and age, we talk about needing not only the COVID, but pneumonia, shingles, influenza, Tdaps. See where you're current, see where you're not, and it helps. Because a lot of the things that we were vaccinated for as children or had as children, shingles, not shingles, but chicken pox. Now we need shingle shots to prevent us from having shingles. So it's helpful to know how current you are on all those things. And again, when you come in with that list of things, bring us your symptoms: cough, cold, sore throat, runny nose, backache, foot pain. Those things are helpful. If you have been to see a specialist, because a lot of times we're supposed to be in the computer age of medicine. Well, computers don't talk to each other because they all have proprietary restrictions on who makes them, and they don't want to lose that information gathering capability. So a lot of times we will not get a report from your ophthalmologist or from your cardiologist unless we are in the same system that they are in. So it's helpful because I'll ask, because I'll know a patient of mine will go see Dr. Grayer, who gave a great speech, by the way, to you guys. And they'll say, well, I had an echocardiogram by Dr. Grayer. Do you know what that result is, Dr. Baker? I don't, because I don't have that result. I don't have access to his records. So if you've got that result, that's very helpful to us. And that's true with x-rays, lab reports, echocardiograms, cardiac catheterizations, those kind of things. And that helps. And that's the same thing is true with outside laboratory results that not are things that your attending physician has ordered. So be aware of that. As a new patient, medical history is very important to know what sort of problems you have had in the past medically, surgeries, allergies, those types of things. And then also what your family history is. Now, sometimes that is forthcoming. Sometimes that is very difficult to get, but a ballpark information about what your family history is very helpful too. And, you know, if they've got cancers or thyroid problems or heart problems, or they're diabetics, they're hypertensives, or they have some kind of unusual disease process that you don't see in people. And I would give you an example of familial polyposis, which is a large colon intestinal disease. And there are people that have that in their genetic history. And so it's helpful to know about that. Being that we're at a diabetic lectures, bring your glucometer. That's always helpful because I can look back and look at your daily tests that you've done. And I would say hopefully daily tests. Sometimes they're a bit scant, but if worst case scenario, at least have written them down and bring in the booklet and have the test, time of the test, day of the test, that sort of thing. That's also very helpful. And you know, and with this day and age, there's a lot of ability to gather that information, both mobile apps, on cell phones, with the new Libre machines. They have all that. You can pull that up, put that on a computer and put a printout out for those things, which are very, very helpful to talk about how you're doing, how you're feeling, if we need to adjust medication. I grew up in the era of calories, not carbs. So carb adjustments are a little bit foreign to me, but I understand some of it. But with the world of with diabetes, knowing your insulin to carb ratio, and also see how that adjustment is that you may need to adjust on this visit, and your sliding scale. And I will tell you that I have a different sliding scale than the endocrinologist, but it's not much different, but it's a little different. And knowing what that is and how that works also helps with being able to adjust medication. As a new patient coming in, if you've never been seen, make sure that you ask the office about their procedures, about making follow-up appointments, about returning phone calls, about returning information on laboratory tests, and about prescription refills. Fortunately, in my office, which is, I believe is extremely efficient, we refill medications same day. Most offices will tell you 48 to 72 hours. Some of them will tell you a week. So be aware of that. So, you know, if taking medications, if you're on something chronically, take it every day. Last thing you want to do is go see someone that you found out that we refill it once every week. We don't, that's when we call in our prescriptions. You don't want to take your last hypertensive medication or your last dose of insulin today and call them in and say, I need a refill today. And they'll tell you, we'll get back to it in a week. It's not going to help you. So it's helpful to know those kind of pieces of information. Other thing that I think is real important is bring a friend. Or if you want to, bring an adversary, but bring somebody that will listen with a different set of ears than what you have, because you may not hear everything that I, as the physician, say to you. And it's really helpful because then, you know, if you've taken some notes and listened to a few things, then you can kind of compare those notes with each other. And, you know, your friend can certainly ask questions if you're willing to let them do that. And then, of course, that brings up another whole issue, and that's called HIPAA. HIPAA is Health Information Privacy and Portability Act. That was passed in the early 2000s. And basically that is to protect all of your medical information from outside agencies, from anyone trying to gather information on you. And there's usually a form that says that, you know, I allow your doctor to talk to your cardiologist or talk to your surgeon or talk to your orthopedic doctor. Do that. And also, is there someone that I, as the physician, can talk to about you if I need to call and say, hey, I can't get you on the phone. I need to leave a message. This is what the message is. Is there somebody I can talk to? So it's really helpful to really understand about HIPAA, because it is your privacy. And so then again, there's some things that you may not want to have a friend in the room for. Okay. But there also is someone, you know, if I need to speak to your spouse or your significant other, I need to have a release to be able to do that, and or your family, because it's not unusual that I will have the second cousin twice removed that'll call me up and say, oh, you're seeing my great Aunt Mary, and I understand she has da 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 da, and I need to know exactly how she's doing and what you're doing to treat her. I can't talk to you. So I have to have that in writing, and they will blow up on the phone and call me all sorts of obscene names, and we can't talk to you. So we have to have, so be aware, we need somebody to talk to, because if you ever become incapacitated, and I will give you an example. I have a patient that unfortunately recognized that he was in the process of having a heart attack at home, lived alone, called 911. By the time they got to him, he was incapacitated. And fortunately, he survived, ended up having bypass surgery and those type of things. He survived, but he was incapacitated for a long enough period of time, and he had no next of kin except for his mother, who lives elsewhere in an assisted living home, who's 98, who has dementia. So it was interesting because they had to appoint a court-appointed guardian for this gentleman while he was on a ventilator, not able to talk, sedated, all this stuff, to be able to do things as basically as the appointed power of attorney. So it's helpful to understand that having somebody that you have as a power of attorney, medical, financial, in your file is really very helpful. Fortunately, this guy has gotten through everything. He's doing much better, but it's just, that's a real extreme example. And as a good thing with this gentleman, he had a list of his current medication in his wallet. So have that in your wallet. And if you change it, try to change that. But that was a fortunate thing for him, because when the EMTs got to him, they were more involved in trying to resuscitate him and keep him alive to get him to the hospital. So that's an example. And kind of lastly, before you leave the office, make sure you try to ask most all of your questions. Make sure that you have an appointment card that's got a date, a time, when you're going to come see us. So that's how I would tell you I would handle both a new patient and a little bit of an old patient. So I would be happy to entertain any questions at this time. Yes, ma'am. Well, I would tell you that as a family practitioner, general practitioner, internal medicine, we are all trained to treat diabetics. And I see a lot of diabetic patients in my office on a regular basis. Endocrinologists, I think on cases that are complex, that's a good direction to go on them. And a lot of times we work kind of hand in glove with the endocrinologist. A lot of times they'll say, hey, we'll see them every 6 months, but you follow them up every 2 months, every 3 months, that sort of thing. And if you need help or change of medicines or whatever, give us a call. And I do. I really like to see my diabetic patients about every 90 days. Part of that is because, you know, if you all have dealt with looking at A1Cs, theoretically, A1Cs, it takes 90 days to see a change. Now, the A1C also tells me a whole lot of things. In one of them, it tells me how bad you're cheating. Okay. And then I can give you either the 1 doctor finger shake or the 2 doctor finger shake, you know? And so it helps a lot with that. And then it helps, then we can work on either adjusting our diet, adjusting your exercise, adjusting your medication, and that sort of thing. And the other thing is it also helps us looking at if you've developed any new complications, because as Dr. Greer talked to you about, I mean, diabetes is a neurocardiovascular inflammatory disease. It affects your nerves, it affects your vascular system. And And so there can be changes in that sort of thing. You may not recognize that, say, in the last 3 months, that you're getting a little shorter breath when you're out walking. And and we'll ask this kind of subtle questions. If you're going up an incline, if you're short of breath, or going up a flight of stairs. And I may have somebody that'll say, I didn't think about that, but yeah, I can only go up about 10 steps and I got to stop. And that's a change. So those kind of things we need to look at. And those are the types of things we want to look for. Not always does it happen. A lot of times everything rolls along just fine. And I get to tell you that you need to quit cheating on the Sunday evening meal, So anyway, yes, ma'am. An A1C is basically it's a measurement of your long-term blood sugar. It's a glycosylated hemoglobin. So basically our red cells that carry our oxygen and nutrients and things like that in our body, they themselves do not absorb glucose out of the bloodstream like all our other cells. And so when they are made, the body puts glycogen into that red blood cell, essentially, much like putting in the pink Eveready battery in as your Eveready cell. So that gives it the energy to go through its life cycle. Theoretically, a life cycle of a red blood cell is approximately 90 days. But our life cycle on our red blood cells are much like our human life cycles. If you look, we unfortunately lose kids early. We have old people that live to be 110. So we don't have this nice 90-day curve but that's the average on the red cell, okay? And so theoretically, when we draw your blood, then we are getting cells that are basically brand new and cells that are theoretically 90 days old. And then you get an average of the glycogen in those cells. And so if your blood sugars are very high when we start treatment for diabetes, we're going to look at that and we'll see what your A1C is at that point in time. And let's say it's 8. And a normal human being that doesn't have diabetes depends on which lab, 5.6, 5.7 is a normal, top end of normal A1C. But let's say somebody has an 8 when they come to see me. So we start them, recommend diet. And the first thing I always recommend, the 2 mainstays of diabetes, regardless of what you do, is diet and exercise. You got to watch what you eat and you need to exercise. You burn calories. After that, then you talk about medications, and there's a whole variety of medications now. I mean, when I started in medicine, we had insulin, and the new thing on the block was metformin. Now we've got 8 different family groups of medicines to look at treating diabetics with. But anyway, so we would start them on a program at day 1 where we got this A1C of 8. So 90 days later, when they come in and we recheck them and we look at their glucometers and or their written down blood sugar readings and see how they're running, but we'll also get that A1C. And, I have quite honestly had patients that will buy into the program right off the bat, and they may be at 8 when I see them the first time, and they may be at 6, which is two units of drop, which is a big drop, which is a great thing. But I may also have the same ones that will go 2 units up in 90 days. So, yeah. Anyway, any other questions? Yes, sir. 15. Now, this is a bad thing to say at a diabetic conference. That person was very sweet. Okay. It's a bad pun and I apologize. Unfortunately, my office staff, Tyler here is a student that's with me this rotation. I have a lot of bad puns, so I apologize. Any other questions? Yes, ma'am. In reality, you still have that process. Now, the people that have undergone gastric bypass surgery that are diabetic, they have a real interesting change in their system. If they follow their diet and those things, there are a lot of them that they have that tendency to go back to being a diabetic, but if they're really strict about it, they will do very well and not have any diabetes. But there is still that tendency. And so again, you still have to watch your calories, watch your carbs. Yeah. Yes, ma'am. There is. Type 1s usually typically will occur, not necessarily, we used to think early in life, but those are people that actually their pancreas just stopped producing insulin, period. As opposed to somebody has insulin resistance, and that happens as they've gotten older. And unfortunately, as we've gotten older, I mean, the vast majority of diabetics I would say worldwide are insulin dependent. And we found there's a whole lot of new medications that have come out, the glutides particularly, and that's a family of drugs that help reduce that insulin resistance. And then there's also the family of drugs called gliflozins that have been used, are now being used not only for diabetes, but they're also being used for cardiac because they work as a mild diuretic, but they also lower your sugar level in your bloodstream too. So there's a lot of changes in diabetes. Like I said, when I started, somebody was put on an insulin sliding scale, given metformin. You were given a short acting insulin, a long acting insulin, and every one of them gained 10 pounds every year thereafter. Now with these newer meds, you don't see the weight gain like it should be. Unfortunately, the newer meds are not covered by most people's insurances. They are, they're usually in a tier 3 or a tier 4, which means they're fairly expensive, but they are very effective. So, any other questions? All right. It is very important, yeah, because if you have somebody that says we're looking at not necessarily diabetes, but let's say hypertension, and somebody says, well, I'm taking losartan for my high blood pressure. How many milligrams are you taking? Well, I don't know. Well, it could be 25, it could be 50, it could be 100. It depends. So yeah, so it's very helpful to know dosage. And the same thing is very true with diabetes, because again, going back to a sliding scale. Well, I've been taking Humulin N or Humulin R or Humalog, and how many units do you take every time you test? And that helps us adjust your long-acting insulin as opposed to, you know, seeing how we do. So, okay. So I'll give you an example about that. So this spring, this fall, I have a lady patient who is very physically active. And she invested in one of these smartwatches. And it told her that she was waking up she was not getting regular sleep, and she was waking up, but she didn't realize that she was waking up to whatever level. She just thought she was just drowsy anyway, and she was having irregular heartbeats, and that showed up on the Fitbit. And of course, there are other monitor devices other than Fitbit, and I apologize, I used a commercial name. Anyway, and so yes, that is very, very helpful to just look at those things. Yes, sir. We do. Yeah. We do. Yeah. And that is also, I didn't put on that, and I probably should have, and I apologize. It is helpful. You need to think about your advanced healthcare directives. I mean, as we all get older, you know, you never know. And well, not even as we get older. Unfortunately, we need to live day by day because we never know if we're going to be here tomorrow. So you want to have a good day today. Thank you all very much.
So we're going to go on a small break right now. We're starting to look into what we're doing for lunch here. And so I advise everybody, or encourage you, go see our vendors. Also, don't forget the van is outside and they do a number of testing and other things. So if you get a chance, go out there. And so we'll reconvene in a little bit, and then we'll let you know when lunch is ready. And so thank you so much. Okay, so we're going to go ahead and get started while we're waiting for lunch to be delivered. And so our next speaker is here, and we got Hugo Mesa, who is here, and he's going to go ahead and be talking about the item, which is it venous or venous? Venous insufficiency. And so everybody, here's Dr. Mesa. Here you go. Thank you so much.
Thank you very much, Ken. So thank you so much for this opportunity to come speak to you guys. Want to congratulate you guys for your continuing education in the medical field, and also the interest in diabetes. So one of my first loves in medicine was diabetes. I worked for internal medicine clinic. As we all know, there's a urgent need for many specialists, especially diabetes specialists. So until we fill that gap, we're gonna need to kind of initiate and take on that role. And as primary care physicians, what we do is that we try to manage these diabetic patients as best we can and get them on control, explain the complications that can arise. And you guys gave wonderful presentations earlier today that kind of explains the pathology on it. And my role today is to kind of hyper focus on one of the complications. I know in medicine, we kind of focus a lot on arterial disease, and we know the complications that our peripheral arterial disease can cause, especially to our diabetic patients. It can lead to foot amputations, will lead to ulcers, it can lead to many horrible loss of limb for these patients. So we want to absolutely prevent that. But I kind of want to take over and kind of give you another view on what diabetes can do as well. Diabetes affects not only arterial, but these patients have an increased risk for developing other complications in the vascular system, and particularly to what we're going to speak today is venous insufficiency and May-Turner syndrome. When we treat diabetic patients, some of the best medications that we have, unfortunately, do have that side effect of leg swelling. I know for the doctors here and the medical students or patients that take diabetic medications, there are certain type of medications that are just famous for this leg edema. And insulin, the TZDs like the Actos, all these, you give them, they work great. We control, we manage, they're doing excellent. But guess what? They come in, hey, doctor, hey, Mr. Mesa, we look at this, and I have these huge legs now. They're swollen, they hurt me, and it's kind of painful to walk now. And you do an ABI, and you check their pulses, and you're doing good, and you give them a little diuretic, and then you send them on their way. But then these changes continue, and they continue, and they continue, and then their pain is getting worse now. They're getting the darkening of the skin, which we're going to talk about. And what I want everybody here to focus on is that there is a venous structure to our circulatory system, which can cause debilitating effects. So my name is Hugo Mesa. I've been a nurse practitioner for 11 years. I'm not from NMSU, not from Las Cruces, but from UTEP, Battle by 10. And I got my master's there too. And then I got a PhD and a DMP from Chamberlain University. So thank you so much for having me here. This is our fabulous team who all work very hard. Dr. Furlong is our interventionalist, Dr. Cook, the vascular surgeon, and Dr. Martinez, Ungar, and IR, and our excellent team of nurse practitioners. So what is venous disease with arterial disease? So venous disease is the main purpose of our veins is to bring that excess volume back up to return it to the heart. We all know the arteries travel, they have oxygenated blood from our heart down to our feet. They feed our muscles, they feed our tissues, but then everything has to make its way back up. So with our arterial disease, we all know it's an inflammatory process. With time, especially with diabetes, these arteries do start getting occluded. Other risk factors come into play if you smoke, hypertension, your diet, your hyperlipidemia. But essentially, it's this inflammatory process. Very interesting. In the past, physicians actually thought they would treat coronary artery disease and this atherosclerosis with antibiotics just because the inflammation was so great. And veins is a little bit different. So veins are meant to have low pressure. They're meant to be loose. They're outside. We have different types. We have deep veins and we have superficial veins. So our deep veins are our famous veins that everybody knows. They're the femoral veins, the popliteal veins, the iliac veins. Those return 90% of all blood back up to our heart. And then we have a series of superficial veins. So superficial veins don't have that luxury so they're outside, they're superficial from our muscles. So they have little tiny valves, and these valves, every time we're walking, every time I'm moving up here, they open and close and slowly move that pressure back up. And what happens is that these valves get damaged with time, the pressures increase and they break. So now when they break, very slowly, but for surely, other valves start breaking, and it's a gradual disease. So symptoms of peripheral artery disease, we all know it's a claudication. You walk, it's hurting. I can't walk from here to my parking lot because it's just giving me a hard, sharp ache in my legs. So you get that numbness, a weakness, they're cold, they're sore. They have a change of color in their legs. So a lot of patients notice they don't have any hair in their feet. They're always in cold. Their pulses, you touch them, they can be absent. They're very diminished. Erectile dysfunction. So those are the very, very, very common, and we're very aware with them. We know that smoking, diabetes, the high cholesterol, the high blood pressure, males that were overweight, all these factors contribute to peripheral arterial disease. And this one, we won't spend so much time because most of us are familiar with the peripheral arterial disease, and that's very important. And of course, for peripheral arterial disease, we get you in a cath lab, we get you in our suite, in an angio suite, and we put a catheter, and we can go inside through the groin area, or we go to the pedal area, depending on the occlusion, and the interventionalist goes in and they do an atherectomy, or they can which balloon it. So they kind of open that artery up where there's occlusion. And in severe cases, we can do even the stenting. And this is the vein disease in a nutshell. So this is, so this is a healthy vein, and the healthy vein moves that blood up in one direction. It keeps everything nice and firm. You're walking, you feel good. And then over here, our patient here, so he's been standing for many years. He has a high demanding job. They're overweight, can't get so much exercise. They don't know about compression stockings that much, so he's not wearing compression stockings. So now his valves are refluxing, and that increase in pressure in the reflux is now affecting him, and now he's having pain. So now when he's standing for 5-10 minutes, he's looking to a seat to sit. Why? Because he wants to sit down, because it's hurting his legs. This is the anatomy of the veins. So we have on the muscle, the superficial veins. It's going to be on the left side. These are the greater saphenous veins, the short saphenous veins. These have valves. These depend a lot on our mobility. And then inside our muscles, we have those deep veins, which return the majority of the blood. And every time we move and we contract our muscle, that blood pressure, that blood moves up and decreasing the pressure. The veins that we have horizontal towards them are called perforator veins. Perforator veins connect deep veins to superficial veins, and we have about 20 of them in each leg. And when we see broken perforator veins, there's a patients that have had this condition for many, many years. And when we have broken perforator veins, patients start developing the venous ulcers, and they start developing the changes of the skin changes of venous disease, which is the darkening and discoloration. The symptoms include the leg pain, the tired, the aching, the itching, the numbness. We sometimes see the bulging veins, not necessarily. We're always going to see the bulging veins. This can be a very meticulous disease, because a lot of patients guide themselves with the bulging veins. I don't have bulging veins. I don't have venous reflux disease because I don't see anything, but that's not the case. You need an ultrasound to examine those veins. We have the burning, the swelling is a big one. So a lot of times when we're treating our patients and they have hypertension and their diabetes is not controlled, and we have to add another medication, and then they have the swelling. So a lot of times we can minimize that swelling. If we can identify if you have venous insufficiency, we can treat the venous insufficiency. Guess what? You can stay on your medications and we get rid of that edema. And then what we don't want to see is the skin discoloration and the ulcers, because that's what becomes a problem. This is our classification of our veins. This is what tool we use. It's been used for many, many years, and we have other tools that they're starting to implement now, the insurances and stuff, but this is the basic one. So you have little spider veins, we call them telangiectasias, and reticular veins, urocepa 1. You have those bulging veins, urocepa 2. 3 is the swelling. So you have swelling, no skin changes yet. That's going to be a 3. And then once you start noticing those skin changes, particularly the dermatitis, the redness, it's going to be a 4. So 4 it's not on here, but it's separated into 2. The dermatitis is the 4A. And then once it starts becoming the lipodermatosclerosis, which is a dark like this, it's going to be the 4B. And that's a huge red flag of venous disease. C5 is when you've had a skin ulcer, but they've healed. Most of these patients have the lipodermatosclerosis. And then a CEPA6 is an active ulcer. And then we know that, like I said, our patients that are standing for a long time, they're not exercising, they smoke, multipara. So if you bring women that have been multi-pregnancies, more than 2 is a huge factor. our age. As we get older, unfortunately, we use that collagen. And then, of course, injury and trauma. If you have patients that play contact sports, you get hit in the legs, football, and then they break those valves, and with time they get huge. The veins get huge. What is the treatment? So treatment is conservative treatment. What does that mean? Compression stockings, compression. You're supposed to wear compression stockings throughout the day if you're standing for prolonged periods of time. Compression maintains that pressure normal within the veins, and it helps to delay that vein disease. Once compression is not functioning any longer, the compression, we move to the next step. So now it's time to treat. So whenever you come to see us and we give you compression stockings, we tell you, hey, you're getting compression stockings, try to wear them, see how they make you feel. If they make you feel better, that means you have vein disease. Why? Because compression stockings only make the vein disease feel better. You have arthritis in your knee, it's not going to help. If you have arthritis in your back, if you have sciatica, if you have muscle, this is not going to have. They come back and they tell me, hey, I feel the same. I start looking at other things. Maybe it's musculoskeletal and not necessarily veins. But with veins, you put them on and they feel great. Number one complaint of compression stockings is going to be they're hard to put on. I can't put them on. They're too tight. I need my husband, my wife to put on. He doesn't want to help, right? So now you come back, you have the veins, it makes you feel better, but you still have problems. So what do we do? So we do radio frequency, and we'll go through them. Ablation, that's also with laser. We have the phlebectomies, we have the Varithena and the Venocil and the stenting. Let me go through them. This is radio frequency ablation. This is what was developed after the laser. So it's a catheter that ablates the vein. So it releases heat, and we put it in we guide it through ultrasound, and we put that catheter exactly where we want to ablate that vein at that section, and they turn it on, and you leave it on for 20 seconds, and it just closes that vein. So it just seals shut. Don't we need these veins? We don't need these veins any longer. Number one, these are superficial veins. They're causing problems. All the blood is just going to be, it already has been redirected to your deep system. So this is the most frequent type. It takes about 20 minutes per vein. It's very easy. We use something called tumescent, which is liquid of lidocaine to coat the vein itself. It serves two purposes. It serves to prevent the heat from damaging the surrounding tissue, and it helps for the anesthetic effect. It's done very, very quickly. It does require multiple pokes. So when patients say, I've had vein treatments before, it was kind of, it was a lot of discomfort. It was most likely radio frequency ablation, because you have to put that needle between the vein and the skin and multiple parts of the leg just to get a good coat around. So not fun, but I describe it as I don't like dentists. So when I go to the dentist and they have to numb and they have to put that lidocaine all around, very similar experience. Very successful results. This is about 99% effective. You're able to walk out of here, the procedure with no restrictions, just no heavy lifting for that week. But you're able to drive, you're able to walk. We do it under local anesthesia. And then we have Venocil. So Venocil is a kind of a new treatment. It's acrylate. It's super glue, and surgeons have been using this adhesive for many, many years on their wounds and their operations. And what this company decided to do is that we put it inside the vein, and it closes that vein up with this adhesive. So we call it, people call it the glue. So it's the same method. So we go into the vein with a catheter, and we put this catheter inside the vein. As we take the catheter out, we're squeezing out this pump and this glue inside that vein. So when we're done, we take the catheter out. This one has no restrictions whatsoever. So you're able to go to work, do your normal routine afterwards. It does not require the multiple pokes for the anesthesia. It's only the one incision to introduce the catheter to the vein. Very simple. This is also 99% effective. This eliminates the risk for heat-induced thrombus. We call it EHITS, so endovascular heat-induced thrombus, because we're not using any heat. So that's, I forgot to mention, for the radio frequency, about 1.7% of patients may develop a DVT from the heat-induced thrombus, but resolves within 2 to 3 weeks with some anticoagulation. This one we say, well, 94% closure rate after the 3 years. We treat it from the lowest point, no anesthesia and very minimal pain. And patients love this one because it's very fast and very painless. No compression stockings are required afterward. Varithena is a foam. So physicians have been treating spider veins many years with sclerotherapy. It's a foam you kind of seeing on YouTube. You put this injection on the veins, on these spider veins, and it just kind of disappears the vein. This is similar. What this company did, they added some nitrogen to it to make the foam travel a farther distance on the vein and cover larger diameter veins. So we can use this foam on these veins. Similar effects, so minimal pain, no anesthesia, no restrictions, no recovery afterwards. So very simple. These, of course, Varithena and Venocil, very depending on insurance coverage, but patients love this one as well. Very fast, and for the physicians as well. And then something new that I want to bring to the table is everybody knows about veins. This is kind of new to the vascular realm, and it's May-Turner syndrome. May-Turner syndrome has been around for many years. Pathologists May-Turner have discovered since the 1800s. They saw their patients have this condition. Nothing really was done of it until recently because there was not a lot of advancement. But what it is that we have these veins, which are the blue that travel our pelvis. These are the iliac veins. And in some people, anatomy-wise, we're born, this goes through and it just goes between the iliac artery and the spine, which is L4, L5. And with time, with skin, with our bones changing, a little bit of arthritis or overweight or lack of activity, this vein gets compressed over time, it gets more and more compressed. This is almost always exclusive on the left side. So there are 7 different places you can have May-Turners. So you can have this is the most common right here. And this is the vein. And we have this artery right there that goes right there. And then here. So we can have it 1, 2, 3, 4, 5 places. And then very rare up here in the vena cava, depending on anatomy. But it's always on that left iliac vein and on that right iliac artery there. That's the most common, but we can have it in different places. And what that does, it does not allow that blood to go return. It's restricted, so it puts a lot of pressure on the distal veins. Patients usually complain of my left leg is more swollen than the right. Say, hey, doctor, why is my left leg more swollen than the right? I have more bulging veins on my left side than on my right. I have a lot of pelvic veins, so that's unusual in patients. When you have a lot of pelvic veins in the buttocks or in the groin area, when women get pregnant and they get big varicose veins on their labia, and that's a sign of May-Turners. And this is an ultrasound that we do. So how do we diagnose May-Turner? May-Turners is the gold standard is an IVS ultrasound, which is an intravascular ultrasound. Intravascular meaning that it's an ultrasound that goes inside the vein and actually measures the diameter from the inner part of the vein in comparison to traditional ultrasounds, superficial. So this one, we do it in the office, is outpatient, very easy. It takes about 5 minutes. We do have to introduce a catheter inside the vein to get access. Veins, thankfully, don't have the complications like arteries, so patients walk out with a Band-Aid and they're able to continue their normal activities throughout the day. And this is what I was referring to. This is the iliac vein to the right artery, and this is the spine. It's just kind of pinched right there. Now it's pinched, and now it's causing problems. 90% of patients that have DVTs or deep vein thrombosis, clots, need to be evaluated for May-Turners because high probability, especially on the proximal veins, that they have May-Turners, and this is the reason for the thrombosis. You get a hypercoagulable workup on blood. It comes out negative. Guess what? You send them to vascular. They do a study, and you have May-Turner. So this is the reason why you had a DVT. And this is how we measure them. The top left is the pre-stenting. So I don't know if you can see very well, but it's the dark shadowing that you're supposed to be nice and open, and it's restricted. You see white on it So we don't want to see white right there. So that's it. Let's compress. They do that catheter all the way through, and we're able to measure, and we use a reference to your own vein. So at your own vein, we measure the diameter, and then at a specific point, that's just the diameter restricts itself and kind of just comes back up. We measure that and we get a diagnosis on how much percent compression you have. And this is post stenting. So before, no one, how they used to treat this up to maybe 2 years ago, they used wall stents, which are for artery stents. And cardiologists love these and they put them, but the problem with those stents, were not designed for veins. Their radial force, or the strongest point on that stent, was on the medial part, so right in the middle. So if the compression was a little bit more proximal, you would have to leave the stent kind of protruding into the vena cava. With time, what that does, it forms like a new endothelial tissue, and patients will get a DVT and you get a clot. So it wasn't favored to do, but now we have different companies. There's 3 actually that make a stent designed for veins that actually has a wall position that fits well, that doesn't collapse, and it's flared, so it doesn't move. So you can put it right. The interventionists can put it right on that stenosis and revascularize with no problem. So people that have chronic DVTs, we've had deep vein clots. We want to make sure we get them evaluated for May Turners, because this can be a reason for their reason for the thrombosis. PTS is post-thrombotic syndrome. Whenever a patient has a blood clot, it's very, very highly likely over the years, it's usually 1 to 3 years, they develop post-thrombotic syndrome. And it's the damage for the superficial veins from the initial clot. Even if you don't have a blood clot anymore, the pressure's still there, the valves are damaged, and then you get pain in the future. So we talked about the DVTs. We know DVTs are dangerous. So this is our clinic. I work at PBS, and we have a clinic here in the southern New Mexico, Alamogordo, Las Cruces, and Deming. We have fully accredited ultrasound, so we can evaluate for deep vein and superficial. Boiling frog syndrome. Dr. Furlong loves this example. This boiling frog is, I never needed to explain to you. You put a frog in hot water, he jumps right out, right? It's too hot, it's gonna get burnt. But you put a frog in water and you gradually turn up the heat. He likes it, it's nice and warm. Guess what? Too late, buddy. So he gets cooked inside. You never notice the difference. So that's what happens with our veins. So with our veins, we do the same thing. We don't notice the difference because it's so gradual. And then all of a sudden you look and you're like, yeah, I didn't have that before. You know, they're hurting me. I don't know when this came on, but it's actually been going on for many years before. So don't wait till your pain worsens or your symptoms worsens. If you notice something, you see something, get it checked. You can get an ultrasound. We tell you you have reflux, if you don't have reflux, and how ways to prevent it. I talked about the locations. We have 3 in El Paso, 3 here in New Mexico. Check everything. So I made it kind of quick because I know we're hungry and the lunch was delayed. So I want to get you guys doing full. So you guys have any questions for me whatsoever? High demanding job. So anybody that has to carry more than 10 pounds as part of their equipment on a daily basis and has to work on their feet. So on their belt, I'm gonna say law enforcement officers, people like that, people in the military, they have to carry a lot of gear and they're on their feet for prolonged hours. Anything over 4 hours of the feet with the gear without a break to sit down, that's high demand. Yes, ma'am. Oh, yes, of course. That's a good question. So we do not. So when we measure the veins, we're getting only diagnosis, and we get the diagnosis, the patient comes out, and they get a consult, and we're gonna go over the results. And then if it was positive, we tell them the benefits, the risk, and what we're hoping to see if they do need a stent. So the stent is done later. It's actually measured. So there's different sizes. There's 10 different sizes of stents on diameter and on length. So we get the right stent correct for their anatomy, and then we stent it if that's the choice, the course we're gonna follow at a later time. That's a good question. So recovery time. So after we do it under local anesthesia, and for some patients, they can have a lot of pelvic and back pain afterwards just because we're stretching out that vein. So there's about 2-day downtime. So of no heavy lifting, take a little bit of time off work, but you're able to ambulate. We're encouraged to ambulate and as much as we can around the house. And we give you tramadol for pain. And then they have to also be on anticoagulations for a month. So after we do stent, the risk for thrombosis in that month is higher. So to overcome that, we do put you on anticoagulation for that month just to prevent that. After that, with just like any stent, you have to be on an antiplatelet agent like Plavix for additional 6 months. So you'll be on Plavix for 6 months, and then after that, you come off everything. This stent is it doesn't get detected by like the metal detectors at the airport. You can still have MRIs. It's made of nickel. It's a nickel and titanium, and it does not have that interference with the MRIs, but no open MRIs. You cannot have an open MRI just because the Telsa reading is not high, but on the regular MRI, you're able to have a regular MRI. Everything we do is outpatient. That's a good point. Everything we do is outpatient and it's ambulatory. So it's either no general anesthesia for anything. It's either local anesthesia or we use conscious sedation. So we have conscious sedation nurses. Yes, ma'am. So anybody can schedule an appointment. So you can call our office and they can schedule an appointment. If your insurance requires a referral, our staff is able to call your primary care or who you're established with to get a referral. We have an excellent team of marketers that we have very good networking within the community that is also able to get that referral from the physicians or from the provider. But you can schedule if we need to do anything. Our staff is great on taking care of you, and we go above and beyond just to make sure we have all the T's crossed and I's dotted. Yes, sir. Reclining is good. The lazy boy is good because you have your feet elevated. So anytime we're sleeping and we have the feet elevated, that's excellent for our venous health. That's what we want to do. When we're sitting for more than 2 hours, we're supposed to do calf pumps, and we're supposed to go like this because that circulates the blood. And we're supposed to get up and walk. Standing, sitting desks are excellent because we're able to do this, and we're tired of standing, we just can sit down. So we're supposed to alternate, but the best is recliner. Do not sleep sitting. That is the worst for vein disease. So if you sleep sitting because you cannot breathe, because of the COPD, because of the congestive heart failure, we need to get that managed because sleeping with your legs dangling is just causing so much damage to those veins because they cannot move up. That pressure cannot move up. Yes, ma'am. Peripheral arterial disease is an arterial process, a pathology. And what it is that the atheromas, cholesterol inflammation enters the lumen of that artery and it inflames it. So it builds up between it. So with time, it closes it and it stenoses it. So it blocks the artery from the circulation. It can happen in your heart. It can happen in your carotid. It can happen in your brain. It can happen in your legs. So with time, like cholesterol, diet, smoking, your arteries start getting occluded with plaque. And essentially that's dangerous because once it blocks off, it's extremely dangerous because you just blocked off all the fuel to and oxygen to that organ. And you can lose toes, you can have a heart attack, you can have a stroke, and the arteries get blocked off. So peripheral, PAD stands for peripheral arterial disease. the treatment for it is to identify that lesion and to revascularize as soon as possible. So we go into the artery and they put a catheter inside and they balloon it. So they go in between if it's not completely occluded, and they kind of balloon it and they squish that plaque and they compress it into the artery to revascularize it. So we open that artery up again. Yes, man. So interventional cardiologists, interventional radiologists, and vascular surgeons are all equipped to manage this condition. Yes. No. So many times, it's normal to see atherosclerotic changes in the arteries. So whenever you have an X-ray and ultrasound, that's almost always going to be mentioned. You get an X-ray your back and say atherosclerotic changes, and that because we start developing when we're like 20 years old. 20 years old, if you open up, we do a autopsy, you're going to see a little bit of already plaque formation in some of the arteries, and this is what essentially kills us as people when we get older, is that our arteries get blocked off most of the time. So yeah, so it depends on how severe it is, and if it's causing symptoms, if it's more than 50%, it's time to get evaluated. If it's not, and it's not causing any pain, any symptom, and depending on where that lesion or that stenosis is, occlusion is, a lot of physicians just kind of monitor it. So it can also be managed that way, man. Thank you very much, guys.
Thank you, everyone. Thank you so much. Lunch is served, so if you want to come on out, we have all lunch ready for you. Thank you. Okay, everyone, we're going to go ahead and get started here and bring everybody else in as we're going. Just a few announcements. First, we have 3 last drawings. Any of you who have not won anything, if you can look at your blue tickets. We have blue ticket ending in 458. We have 460 and 464. If anybody has those blue tickets, let me know. Okay, and remember to fill out your blue evaluation sheets and turn those in before you take off. Okay, and so I'm going to go ahead and start on our next topic here, which is prepare for the unexpected. And we have Ron Schulmeister, Kim Schulmeister, and David Deal. And I'll go ahead and turn this over to you. Whoever wants the microphone, and good luck, okay?
You have the lapel.
Okay.
Thank you. Thank you very much. Everybody have a good lunch? Good, good, good. Sorry for the lateness of it and everything. Thank you for being gracious and flexible with that. We'll get started right now on our next presentation here. My name is Ron Schulmeister. I'm retired Las Cruces Fire Department. The last 5 years there, I was the training officer. Also during my time there, I was also on the local emergency planning committee, where I chaired their exercise planning and development subcommittee, putting on very large scale exercises for all the different emergency response agencies around here. I'm also an adjunct instructor for the New Mexico Department of Homeland Security and Emergency Management for Incident Command System and Homeland Security Exercise and Evaluation Program classes. So that's a little bit about my background here. The lovely lady next to me is Kim.
Hi, I'm Kim Schulmeister, and I'm not as impressive as he is as far as emergency management. I am a nationally certified school nurse, and I also co-lead the Southern New Mexico Diabetes Outreach Type 1 group.
I don't have a mic. Sorry. I'm David. I'm not as impressive as these two. I'm just a diabetic. I do co-lead with my mother the Southern New Mexico Diabetes Outreach Program. That is every first and third Tuesday of the month. And we have fun, eat snacks, and talk amongst ourselves. I graduated high school, going on to college, and that's all about me.
Thanks, David. All right, so we'll get right on into this.
Actually,
Oh, I'm sorry. Kim would like to tell yes.
yeah. So when we were asked to present this, prepare for the unexpected, a lot of times we think of disasters as something massive like hurricanes and tornadoes and things that we don't really see in New Mexico. But an emergency or a disaster situation can be something as simple as breaking down in a car and being prepared for the unexpected. Adopting a 16-year-old diabetic, our first trip out of town, we were up in the mountains in Cloudcroft in snow. And, you know, having diabetics in the school, of course, that was a school setting. Having one at home, totally different. So we get up there and we have no insulin, no extra sets, no supplies. And I'm thinking, I hope this pump doesn't fail. So emergencies can be all kinds of situations.
Definitely they can. And we'll talk a little bit about several of them. Diabetes is already a 24/7 responsibility. You already have to watch kind of what you eat. You may not have a restricted diet, but you have to be able to count carbs and account for you to give yourself insulin before eating. You're already having to deal with it, you know, highs and lows sometimes. That doesn't go away in an emergency. If anything, it becomes more difficult because the added stress now can do strange things to your blood sugar. As the added stress of the emergency. So you need to be able to handle that in addition to the emergency. It can be, you know, more difficult to do that. It is necessary to prepare. If you're prepared as you can be, it makes it just that much easier to be able to manage your diabetes and the emergency at the same time. And like Kim said, it doesn't matter the size of the emergency. It could be just your own family, caught in the mountains, caught hiking, out on the road one night somewhere, all the way up to a national disaster, a terrorist event, a hurricane, anything like that. Okay. So have a plan. First and foremost, have a plan. I know you guys have all heard that before. You probably also heard if you fail to plan, then you have planned to fail. And it is very true. You need to have a plan. But it doesn't have to be this 40, 50 page full paragraph drawn out plan. It can be as simple as a checklist of what you're going to do. No different than having a fire plan or an escape plan at your house or at the school. Schools have fire drills all the time. They're practicing that plan of evacuation. It can be as simple as that. A checklist is a really good way to get going. Set up a checklist. If something happens, if you lose your power, the house is flooding, something, have just a checklist. We're going to grab these supplies. We're going to call this person. We're going to check in with this emergency contact, that type of thing. If you actually have to leave, just have a written out plan, a checklist of what you're going to be taking with you. And a go bag, what we call a go bag, is very important because it's what you can grab and go if you have to leave in an emergency. If you don't have to leave, if you don't have to evacuate your house, you still have the bag packed, ready to go, that you can open up and use what's in it for the emergency, even though you're staying home. As far as the plan goes, there is actually in your packet that you got in the folder, there is a document that looks like this. It is a checklist already of how to set up a go bag, different types of information and items, supplies to take with you to put in that go bag. And we're going to be talking about a lot of what's on this list here today. There's also one in Spanish in there if you want a Spanish one. Very good resource. I recommend a backpack style. It may not quite hold as much as a large plastic tote, but it's not plastic. It's not going to crack or get broken. Also, with a big tote full of stuff, anything you want is always going to be at the very bottom and you're going to have to dig for it. It's just the way it works out, right? So a backpack has different pockets. You can separate out clothing, medical stuff, bottled water, that type of thing in different pockets of the backpack. So it makes things much more accessible. It's not quite the same as the everyday carry bag, the EDC, that a lot of diabetics carry. David, where's your bag? What's in your bag?
My bag has the essentials for a diabetic, a emergency glucagon kit that goes up the nose, my checking supplies, an extra set, and batteries. It also has everything I might need on a daily basis: not toothbrush, floss, gum, and other essentials.
Okay.
And also has a snap just in case
Also
you
has
go
snacks,
low.
yes, just in case it goes low, there's like little gummy snacks and stuff like that in there. In case he's at work or at school or something like that, he's got that bag with him. So in a way, it's kind of like a mini go bag. It's kind of for emergency type purposes. If something out of the ordinary happens, you've got some extra supplies or extra snacks or something like that. So it's kind of like a mini go bag. And it's very easy if you have a go bag ready to go. You could grab your everyday carry bag because you're already used to that. It's already a habit, but then just grab that in your go bag and you should be good for several days.
As far as the go bag, I would suggest carrying the nasal glucagon. David, can you get that out? This is really easy for non-medical personnel. So if you're unconscious, it's very easy to administer and has simple directions on it. So you just spray it up the nose. So very easy. It's a lot easier than the glucagon kit.
So in your go bag, what kinds of things do you want in your go bag? Well, first of all, information. You want to have your full name, date of birth, that type of thing. So people, if somebody finds you and you're unconscious, they can identify, you know who you are. You'd want to have a list on there showing that you are a type 1 diabetic and the medications that you take. Also include the recent lab results.
Yeah, and those recent lab results are important because we need to know what your normal is. So for some people, they might run a little higher, a little bit lower. As far as their blood sugars are concerned, their A1C might be a certain level. It's good to know where you started to know where you presently are.
Right, because if somebody finds you unconscious in the middle of a street somewhere, they don't know what your baseline is. All they know is what you're presenting with right now. And they don't know how that would compare without that. Also, any other medical conditions you might have. Of course, they don't go away in an emergency just because you have an emergency and you're a diabetic. You still have any other medical conditions you might have. If you're hypertensive, lupus, CHF, congestive heart failure, whatever you might have, make sure that you've got those written down too, so people know what your conditions are. All medications that you take, preferably list the dosage as well. If you're allergic to any medicines, that's very important to include as well. Contact information for your doctor, primary care physician, endocrinologist, the pharmacy. I can tell you on fire scenes, there have been times when we've come across people that were unconscious and we had that information out of their pocket or what have you, and we've gone ahead and called. We have this patient, this is the name on their ID, this is their date of birth. What can you tell me about them? Why might they be laying here in the middle of Picacho Avenue on a Sunday afternoon? We really do use that information. So have that information for yourself as well. And emergency contact information, who other people can call in an emergency, a friend or relative or something like that.
Yeah, and as far as the medication allergies, again, this is very important because like with David, what are you allergic to, David?
I'm allergic to Novolog, which is a type of insulin.
Yeah, so you can see why that would be a problem if he was unconscious and his sugars were very high and they were to want to push some insulin if his pump wasn't working, would not be a good plan.
No. So that would be very, very important to know. Humalog is fine. Novolog is a big no-no. Okay, so some supplies that would go in your go bag. We'll start several slides of these. At least a 1-week supply of diabetic medications. Whatever you take, have at least a 1-week supply. We actually prefer a 30-day supply. And you could sometimes get doctors to prescribe you a little extra so you can have that extra. Pharmacies also will sometimes give you extra, especially if you live in a known area like say Florida and a hurricane is coming and it's expected to hit within 3 or 4 days. A lot of times pharmacies will give you some extra because they know that you might run out during that time. Okay. So again, 30-day supply is preferred. Sometimes when you're, say you're prescribed your insulin and you use some of it, but you might only use 60, 70, 80% of it by the time you get your next month's prescription filled. Keep using the old until it's gone and then start the new. Well, now by the time the end of the month comes, you may be only half through that vial when you get your next prescription. And so over time, you can actually build up some extras. And this is a good thing. That's actually a good thing because then it gives you some in case of an emergency, flood event that where you can't leave your house for several days or what have you, you've got some extra then. Let it build up that way. Always use your older first though. Finish your older before you start the new. That way you don't have open vials, or you've got one vial that's been sitting in there for 4 years in your refrigerator. Always rotate them through so you're using the oldest last, and your newest one is your extras. And again, don't forget any other medications you might take, any other medical conditions you might have that you take meds for. They don't go away when there's an emergency. So make sure you have some extras of those too. Build up some extras the same way. As far as insulin goes, what's special about insulin?
It's got to stay within a certain temperature range. And if it doesn't, it can be less effective.
So here we have very simple little lunch kit to take your lunch in. It's foil lined. It's an insulated cooler, and there is a refreezable gel pack. Some of them are like, soft like little pillows, and some of them are hard like this that you just put in the freezer. Keep some of these in your freezer. I recommend the freezer door so they don't get buried by other items. They're right there when you open the door. And if something happens and you need to leave quickly, that's the one thing that's not going to be already in your go bag ready to go out the door, is your insulin, because it has to be kept refrigerated. So you would have a few of these, you would put them in, line the front, the back, the side, put your insulin in, put one over the top, zip it up, and then that would get stuffed in your go bag. And now your insulin will be kept cold for quite a while. Oh, well, true. No dry ice. No, yeah, don't use dry ice. Use the little refreezable. You don't want to freeze the insulin. You don't want to freeze any of your liquid medications. So make sure that it won't freeze. But those little refreezable gel packs won't freeze your insulin. They'll keep it cold.
And then with extra infusion sets, syringes, lancets, things like that, ketone strips. Also make sure that you have some extra on hand. We had a situation with David's Humalog in that his insurance was refusing to pay for that. We went back and forth with things. It was great to have extra supply. So again, when you think of emergencies, you don't think, you think of, like I said, the major things, right? But a simple emergency could be not having what you need on a day-to-day basis and needing to have some of those reserves. And so thankfully he had enough in reserve, right, David, to be able to get through it. As far as if you're a parent of a diabetic, I suggest taking one of their sensors or some of their infusion sets or whatever, especially teenagers and below. They'll sometimes forget when their supplies are running low. And it's kind of nice for you to have that and be able to give it to them and say, okay, that's the last one. Let's contact the company and make sure you're getting what you need.
Thank you. Yeah, so the insurance company is saying we're not going to pay for this anymore. Can that create an emergency? Again, they don't have to be big, huge national events. It's just an emergency is anything that disrupts your normal way of living, your normal life. If a disruption comes in that can cause a problem, that can be an emergency. Emergency therapy, not just your normal meds and everything, but emergency therapy, the glucagon, syringes. If you're normally on a pump, the syringes, if you normally inject with the syringe, you've got some extra anyway. We just talked about it in the previous slide, but if you don't, if you have a pump, have some syringes on hand just in case for an emergency purpose. Insulin pen, that type of thing.
And actually, I'm going to let David go over some of the things, the sources of carbohydrates, because I know he personally doesn't like glucose tablets, right? So what are some of the things that you can use?
Some of the things that I would use is like dried fruits, hard candies, gummy bears, stuff like that. Stuff that doesn't really go bad, but something that will also bring your blood sugar up in case you don't like to use it or you can't use it for some reason. It's always good to have those types of extra things in a go bag.
Actually, I'm going to hand this over to you too, David. Yeah. So the empty plastic bottle is good for a sharps container. So, and if you've already crushed the bottle and then just reinflate it, then you can use that and just put your needles and your lancets in there. So it's pretty cool. It's a makeshift sharps container and it's obviously space conscious.
Space and weight conscious. It doesn't take up much room. Make sure you crush it and hold it while you put the lid back on. That way air won't let it reinflate. It creates a little vacuum and it will stay flat. It's very light. You can say, well, I'm taking some bottled water with me anyway, and we're going to talk about that next. I can just finish this bottle. But that kind of puts you in the mindset of, I have to finish this bottle. So where you may not necessarily need to be taking a drink right then, you've just used one of your bottled waters up that you might need a couple days later when you do really need it, just to be able to get yourself a sharps container. So just take an empty one extra with you, crushed to save space, and then you won't be hurrying to use up your supplies just to get a sharps container. And bottled water. Obviously, it's going to go in a go bag, right? You want to take bottled water with you, at least a 3-day supply. We recommend at least 1 gallon per person per day. With diabetics, sometimes they are thirstier than the average person. So you might need to think about taking a little bit more than that. I understand all that bottled water won't necessarily fit in the backpack or any other type of go bag, duffel, or whatever you choose to use. But it's, have an extra case or so, or some of the bigger gallon size store-bought jugs already to go next to the go bag, so you can just grab them all at the same time. It doesn't have to be actually inside the bag, as long as it's there ready to go in the little coat closet inside your front door, or wherever you have it where it's convenient to run out. How many know how long bottled water will last? Anybody? Nobody? Indefinite. Indefinite. Store-bought bottled water that you have not opened yet can last for years and years and years, if not decades. A lot of companies will put an expiration date on it, generally 2 years out. That's simply because over time, the plastic will start to cause the water to taste funny. It won't taste as good, and they don't want their brand name associated with water that doesn't taste very good, obviously. So they'll put an expiration on there. But if you haven't opened it yet, it should last for years and years and years. It may taste funny. It's not going to be bad for you though. But you can still rotate it out. Every couple months, throw a different case and take that one back or whatever. And then you don't have to worry about that problem. However, if you take a bottle, wash a bottle out and put water from your faucet, kitchen faucet in, that has a shelf life of about 6 months. And after 6 months, you'd want to dump it, wash the bottle out again and refill it. If you happen to see any cloudiness to it, any solids floating in it or anything like that, consider it bad right then and dump it and refill your bottle or get new water right then.
No floaties?
No floaties.
Okay.
No floaties. Batteries, batteries, batteries. Okay. Very, very important to go into a go bag. Anything that might be battery powered, you want to have extra batteries for. At least 2 extra rounds of batteries, not just 1. If you have a insulin pump that takes 2 batteries, you would want to have at least 4 batteries in your go bag. So you have 2 different battery changes. Thing about batteries is sometimes they leak. So you don't want to wrap them all up in one bag or Ziploc or anything. You want to keep them maybe by 2s, or if your pump takes like three AAAs, you'd want to put 3 in a bag, put the other 3 in a different bag, a Ziploc, and take 3 or 4 of those baggies of batteries. And if you pull one out and one has leaked, it's only ruined what's in that bag, and not all of your batteries are going to be ruined. Non-perishable food items. This is where it adds a little bit of weight to your backpack or your go bag. So kind of be cognizant of how much food you might need. Again, we say at least 3 days worth. So plan on however many people you're going to have to feed for at least 3 days. You need to have that much food. If you're having to leave your house or you're trapped from flooding or whatever, you want to have that with you. Short term, we talk about nuts, dried fruits, peanut butter crackers, that type of thing. But those can also go bad over time. They can get rancid. So we also suggest some long term, some canned tuna, or the pouches that you can tear open of tuna, canned vegetables, beans, stuff like that. Don't forget a couple spoons. Every canned good is cooked. Everything that you buy that's in a can is cooked already, sometimes for hours and hours and hours. That's why your green beans are so mushy. So you don't have to be cooked to eat. You can eat them right there out of the can. You might not be used to eating, cold pork and beans. They might taste a little funnier than normal, but they've already been cooked. They're ready to eat right out of the can. Just open the can and start eating. Try to use the cans that have the pull top lids nowadays, so you don't have to have a can opener with you. Makes it much more convenient. And then 0 carb foods. It's good to have some meat sticks, beef jerky. David, why do you think that's?
so that if you run out of insulin or you do not have insulin in that emergency situation, you can still have something to eat.
Exactly, exactly. Or if your insulin is starting to go low, if maybe you just didn't have enough extra in your go bag and you can see, I'm going to be here for 3 or 4 more days, and it looks like I only have about 2 days of insulin. You need to start kind of rationing it a little bit, start going to a 0 carb diet there with your food, and then you can get through that.
Yeah, and it's much easier to control, as David had mentioned at some point. It's much easier to control a high blood sugar than a low blood sugar. Low blood sugar needs to be treated. A high blood sugar you can control with water and exercise and 0 carb foods, things like that, so that you can survive. So we're talking about survival mode. So this is not optimal, but it is a survival way to and make sure you have your ketone strips with you. And that's where you're going to need more water and things like that. So want to add to that? Nope.
Okay. Flashlights, big item, just like batteries for a go bag. Candles are obviously not recommended, not only for in case you get too close to one, your hair or your clothing or a blanket or something gets too close, you can catch fire, but also just having an open flame, depending on what if you're in a disaster, it's not just a small level emergency. If you've got building collapses, earthquake, that type of thing, you could have broken gas lines. And so you don't know exactly how much gas is in that area at the time. So you don't really want an open flame. Flashlights, however, can be big and bulky. We recommend just a small flyover for the football game.
Oh,
No emergency, no disaster here. It's just a flyover for the start of
land the plane.
start of the game. Hopefully they hit it right during the national anthem again. So small flashlights are available pretty much all over the place. This one is waterproof. It's aluminum, so it's very strong. They're very bright. And you can fit 3 or 4. That doesn't weigh very much. You can fit 3 or 4 in multiple pockets of a backpack and have flashlights to go. You can also, this is a little bit bigger, but it's not very heavy. They have some lanterns that actually will light up a whole room. You're not going to read a novel by the light, but it's definitely light you can survive by during the night, during dark periods of darkness. So make sure you have some flashlights with you. Rechargeable flashlights are preferred. If you use batteries, a battery flashlight, make sure as much as possible you try to match the batteries for the flashlight with whatever's in your insulin pump, your CGM, that type of thing. We're going to talk a little bit down the slide there. You'll see it says the emergency radio. Anything that you have that takes batteries, try to make sure that everything you have in that go bag takes the same size battery. It's not always possible, but it's a whole lot easier if you just have to carry one size battery with you.
And also back to the battery, make sure too that that you buy the nicer batteries, because they do tend to last a little longer, the Duracell and the Energizers.
Yeah.
David, do you want to tell them your battery story?
We were on our way back from Cloudcroft, and my pump was running low on a battery. I thought I could make it, and it just ran out on the overpass. And yeah, and we had to stop the other car we were riding with to see if we could find some batteries, and we found one, and it was in a flashlight.
You make do, right? It's not, life's never perfect, and we all forget sometimes, and so you make do.
Yeah, my son in his vehicle had a flashlight that had the same size battery, and it would have been okay if we were at the overpass, but we were probably 30 minutes. I mean, we passed Alamogordo, but we were like halfway. We couldn't really turn around and go back. We couldn't keep coming. We had to do something quick because his BGL was over 300 already. So we needed to get that battery. A little bit of a lesson. First aid.
And so with first aid supplies, again, if your water source is limited, diabetics are more prone to infection. So if you were out there in a muddy area or in an area with debris and stuff like that, you're going to want to clean the site before you put in before you would inject your insulin or put in a new set or check your blood sugar. So having those alcohol wipes, really easy and, small, lightweight to throw in a go bag. So, and those are really cheap to find. Bandages, antibiotic ointment, again, prone to infection. So you want to make sure that you have those on hand.
Thank you. USB charging bank. I've got an example of one here. This is actually a solar powered one. I can just lay it on a windowsill and a little green light pops on and tells me it's charging. And when it's done, the light goes off. I can also charge it from a computer or from a wall plug-in on a USB cord. It's got 3 different ports. I can charge 3 different things, 3 phones or what have you at the same time, a flashlight and a phone or whatever you need to keep charged. This one also happens to have 21 LED emergency light with it, nice and bright. So I've got an emergency light right there. It's lightweight, it's pretty small, and that way you don't get trapped out in the middle of nowhere in the mountains or something and you can't call, you can't make any calls or anything because your phone has died. So try to have a charging bank with you as well. Emergency radio, I don't have one of those to show you, but they're very small. They're about the same size, a little bit thicker. They usually have battery power and they're rechargeable with the USB port. Also, some of them have a little hand crank that you can crank the little crank for about a minute and it'll give you about 15 minutes of power to listen. You can talk to, or you can't talk, you can listen to different types of news stations, information about whatever the emergency is, weather channel, you can pick up some weather reports from there as well, and that type of thing. So an emergency radio, just if it's one of the big large scale disasters or terrorist events, it just kind of lets you know what's going on out there. You can keep up with what's happening in your area so you know when you can go home and that type of thing. And then a pen and pencil and notepad, that can be very important. That can go back with your informational stuff in an envelope when you're giving all your information that we talked about at the beginning. Very important to write down your BGL readings when you're checking your blood glucose level, and the time. And if you start feeling any symptoms, if you're feeling bad, you start getting any symptoms, you'd want to write those down too in the time. So in case you end up unconscious and somebody comes across you, they can kind of read there and see what was happening with you, see what your symptoms were, even though you can't tell them, and they can kind of get an idea of how to treat you. Some other things to consider packing: extra clothing, especially warm clothing in the winter, or loose clothing in the summer that covers as much skin as possible for sunburn purposes. You want to have some extra clothing with you. Blankets. Now you're thinking, okay, now you're getting big and heavy again, but it doesn't have to be a big fluffy blanket like you get at the hotels. I like to say that I can judge how good a hotel is if I can close the suitcase when I'm leaving, because the blanket's not that puffy, then it's not a very good hotel. If I can't get my suitcase closed, they've got really good blankets, it's a good hotel. Just kidding, I don't steal from hotels. Kim does. So blankets, but the thing about something like a blanket, it doesn't have to be a big, warm wool blanket. I've been actually carrying in my pocket a blanket the whole time I've been standing here talking to you. It can be as simple as an emergency blanket like this. This is a blanket. It will cover an entire person. It's silver, so you look like a baked potato, but it's reflecting about 90% of your body heat back to you. It's windproof, it's waterproof, and it's a survival blanket. Again, we're not talking about the Marriott here. We're talking about survival. So you can actually fit 5 or 6 of these. It weighs 2 ounces. You can fit 5 or 6 of them, a little stack in your go bag, and you'll have a blanket good enough for everybody in the family. Water purifying tablets. In case you run out of bottled water and you're going to be somewhere, or you're stranded somewhere for an extended amount of time, your bottled water is only going to last so long. So we suggest extra water. Doesn't necessarily have to be the clean bottled water. It can be right from the kitchen tap, but for washing your hands, that type of thing, to try to keep from getting sick. But then also water purifying tablets, or one of those life straws. If you haven't seen a life straw, it's a tube about that long. It's about 1.25 inches around. It's got the little mouthpiece on one end, and you can just stick it in a lake, a river, other places.
You should tell them where they actually tested that.
If you go online and you're looking for these life straws, there's some of the advertisements out there where somebody took a life straw into a McDonald's restaurant and drank out of the urinal. I would not do that personally. I would not want to do that personally. But they are very good. It's a filtration. As you're drinking, it's filtering water right through there. So it's a very good item and it only weighs a few ounces. It's about 8 or 10 inches long. Like I said, it's about 1 1/4 inch around. Bless you. And so it's very good item to have especially if you're doing much like hiking or up in the mountains or something, and you get stranded or something happens. It's a very good item to have. Photo ID, health insurance card, and some cash. Again, think about packing some cash. It's always good to have in case you're out and you get stranded somewhere. Your health insurance card and photo ID should be with all of your informational stuff we talked about at the beginning. Some other things to consider. Most emergencies, we don't have a lot of hurricanes here. We don't have a lot of earthquakes. We get high winds, we get some power outages and some flooding sometimes. So a lot of our emergencies, we don't actually have to leave the house. Sometimes we may get trapped at the house for a day or two, stranded, or we're without power. We could leave, but we're without power. But we don't always have to grab a bag and go. So look, since we're trapped in our house, a lot of the times for our local emergencies, some things to consider are keeping some pitchers of water in the refrigerator, or some large bottles that you rinsed out from other water or juices and put those in the refrigerator. Again, diabetics need to drink more than the average person. So it's good to have that extra water. And if you live in an area where you're not on a municipal water system, you have a well. If the power goes out, you have no more power. You don't have water because your pump won't work without that power. So you might just have a power outage, but if you live out in the county on a well, you don't have power or water. So keep a few extra bottles in your refrigerator just for times like that. Any special dietary needs? When you're looking at packing your go bag with the different non-perishable foods and everything, don't forget what your normal dietary needs are. You might think, oh, cheese sticks would be a great thing to pack, but if you're lactose intolerant, they're not going to be a great thing to pack. So make sure you don't forget what other conditions you have as you're preparing for an emergency and you're a diabetic. Vaccinations, keep them up to date. Those can be very important. In case of a building collapse, a mass pileup on the interstate that you might be a part of, something like that. You end up with jagged metal, different things you could cut yourself on. It wouldn't be fun to catch your leg on a torn up fender of a car and you don't have your tetanus shot up to date. So keep vaccinations up to date. Medical alert, medical ID bracelet. David, do you have one of those? Notice he's got one right there on his everyday carry bag. If you don't like wearing something like that, okay, but at least get one of them so you can put with your go bag or hook it onto your everyday carry bag. At least it's right there with you. You can put it on if something happens. That way, if you are found unconscious, you've got it right there with you. We didn't talk about this, did we?
Nope.
Speaking of bracelets, though, and this kind of goes back to the emergency supplies.
Yeah, for the hypoglycemia. And those who are in the diabetic group, you recognize this. And I see Joseph's tag there hanging. Good job. So basically, this is a way to access your glucose if you're in a situation where you're running, you're jogging, something, and it's on you. So what you can do is you can unhinge that. How do you work it, David? You actually take off the end and you can actually suck out of the tube. So that's the glucose. Now, it can harden over time. Yes. Oh, nice. That's good to know. Because again, if you're low on sugars, I mean, wouldn't you rather have something that you like to eat rather than something you don't like to eat? So you can just wear that and jog with that.
Bike
And
ride, hike.
it's rubber, so it's going to be waterproof and things. Make sure you check these on a regular basis because the glucose can harden in there. So you want to be careful with that. Nice. Thank you.
Keep the gas tank full of your car in case you have to go. I say when predictable. What I mean there is by if it's like a weather event, a hurricane coming in, a whole lot of rain predicted, and you live in a flood prone area, that type of thing. If you can see a few days out, I think most people in Florida get like 8 days notice if something big starts to build off the coast of Africa before a hurricane hits. They have several days to prepare. So if you know something's coming in, Obviously, an unannounced emergency or short notice emergency, you're not going to be able to probably worry about that. But if you know something's coming in, keep your gas tank full, fill it up so you can leave in a moment's notice.
For any time though, you should not get below a quarter of a tank. I last week was running on 1 mile left in it, so don't do as I do. It's not a good idea to push the car.
And choose a meeting place. Just like, I don't know if anybody's ever gone through the school systems when the fire department comes in and teaches Edith exit drills in the home on how to get out in case you have a house fire. And one of the big things is have a meeting place. The whole family gets out whatever door or window they can based on where the fire is, but then everybody meets at one place. So when responders show up, people know there's someone inside or there's not anyone inside anymore. And it could be the big tree in the front yard, the mailbox by the sidewalk, that type of thing. So for this case, choose a meeting place. If you have to leave the house, some people are home, some people are at school, some people are at work, no one's at the same place. A flood happens or something hits and you can't get home, where's the meeting place that everybody designated? Is it your church parking lot? Is it a store somewhere? The mall, something like that? Just have a place where everybody goes so you know that everybody can reunite and be together again.
And we're running a little close on time, so I'm just gonna make another point about the meeting place. Always choose a second place. Ron does recommend that. I know, I'm just trying to concise it for time. But so that if that first meeting place is flooded or something else is going on, then you can have a safe meeting place.
Some other things to consider: automatic garage doors. If you have an automatic garage door opener, most of them, especially the newer ones, have a battery backup. But in case that also fails, or you have an older one that doesn't have that, does everybody know how to open a garage door that's on an opener if you have no power, no electricity? Everybody knows. Some people are shaking their head. Great. If you don't know, down toward the bottom of the door, there's usually a cord about that long with a little red handle on it. If you yank on that, it will disconnect the door from the track. And then you can just grab it and push it up by hand or pull it back down by hand. If you've never seen that, go look for it. I would suggest you practice with it a couple of times, preferably with someone who knows how it works so they can hook it back for you. If you don't get it hooked back right, then it won't work afterwards. So you want to be able to hook it back up, but that's your emergency for the garage door.
They can also be right next to where the motor is up at the top.
There could be a pull cord up there as well. Pre-packing the car trunk. Again, you're not going to want to put a lot of perishables in there. You obviously can't put your insulin in there. You don't want to put a lot of batteries that could leak in the summer heat inside your trunk. But you can put like a tote bin with some extra blankets, umbrella, poncho, raincoat, that type of thing. You can have some items in the trunk of your car also that just ride back there. They don't take up much room, just a small little carry tote with some of this stuff. And then you don't have to worry about all of it being in your go bag. Some of it's already would be in the car. It's also a good idea to have like a first aid kit and that type of thing in there, because you could be out somewhere away from the house when something happens and you can't get to your go bag because it's back at the house. Consider automatic check-ins. What I mean by automatic check-ins is a friend or family member that you've already made arrangements with, that if something happens in either one of your area, you're going to call that other person and let them know you're okay, so they're not worried about it. If they don't hear from you, they will try to call you. And if they can't get a hold of you, they will start calling the authorities where you live to let them know this was our arrangement and I can't get a hold of this person, so something must be wrong, that type of thing. Prefer somebody who doesn't live in your area, maybe a relative that lives back east or California or something. So that way a regional wide, like a regional weather event or something would probably get both of you if you chose someone in the same town or same county.
And then with warm or expired insulin, don't throw your insulin away in an emergency situation, because you can use expired insulin or warm insulin. It's not going to be as effective, but you can use it. And I couldn't remember what I wanted to put on this slide, and the insulin is reminding me. Back to your paperwork, make sure that you have a list in case of a pump failure of what your insulin sensitivity ratio is. And so that's how your body responds when it gets 1 unit of insulin. Okay, so how far will that take your blood sugar down? And what your carb ratios are, what your basal rate is, that's the amount of insulin that you're getting in a 24-hour period. So that's your constant level of insulin, not your boluses that you would take for a change in blood sugar and for your food. So make sure to have a written list of that. Most of you guys, when you go to the doctors, will be handed those lists anyway. So you'll know what's in your pump.
Thank you. And insulin is not the only medication that's works on. Most medications, obviously liquids aren't as good, but most medications, pill form, they last a lot longer than the expiration date. Just because it's expired doesn't mean it's bad, it's going to hurt you. It just won't be as effective. Federal law says it has to be at least 98.5% effective. And so once it starts to degrade over time and it gets down to below 98.5, that's where they have to list the expiration date. Well, if I'm in an emergency and I need a medication and it's only 90% effective, I'm fine with that. I have no problem with that. You may need to take a little bit more, but you'd be fine with it.
So if you do have extra medications and supplies, this is a good website to go to. I know Miss June also has, and TJ have also some places where you can donate supplies, but these cannot be expired. So if you have changed pumps or you have changed supplies or something, have an extra glucometer or medications, then they will take that for people that are in disaster situations.
Just don't donate the amount that you're holding back for your emergency supply and your go back. So redundancy is vital in preparedness. If you've, like Kim said, if you've recently changed your meter and you've got an old one, throw it in your go bag, just in case something happens to the first one. You know the other one worked because you've been using it unless you replaced it because it broke. So throw that in there. Again, batteries, extra batteries as much as possible. Extra socks. Warm, dry socks can be pretty important for a diabetic. They can sometimes get foot ulcers and that type of things, and they don't heal as well. If it's a flooding situation and you're standing in water half the day, you want to be able to take care of your feet. Very important for diabetes. And again, like Kim mentioned, more than one meeting place, preferably one like higher elevation, just for flooding purposes and stuff around here. Redundancy there. An old cell phone. If you happen to have an old cell phone, even though it's not activated anymore because you got a new one and they activated that one, that old one, you can still call 911 on. You can still turn it on, dial 911, the call will go through. You can't call anybody else. You can't get a call on it, but you can call an emergency number. And then at the end, don't carry a half-empty go bag. If you put all the stuff in there you think you're going to need and all the stuff on the checklist, everything we've talked about, and you've got some extra room in there and it's not overly heavy, put a few extra batteries or a few extra socks, a few extra flashlights, something like that in there. There's no reason to, if you've got an extra compartment in there, not to put stuff in it. You never know what you're going to need there when you might need extras in an emergency. So any questions? You did really good. You covered it all perfect. They have no questions. Okay, thank you. So there's some contact information you can jot down if anything comes to mind later.
Thank you.
Thank you.
Great.
Thank you.
I don't think I need it. So let me go through a few things here. First of all, remind everybody, take your blue sheets and get those filled out so you can turn those in when you leave. Number two, we have a few extra sunshades up here. If you didn't get one and want one, please help yourself to them so we don't have to take them back. Last of all, we have, when you leave, we have a blue light bulb, and this is National Diabetes Awareness Month. So for that, anybody who wants a blue light bulb, we have one per family, so we can give those to you as well. I have to check with June just to see. I know that we had one more presenter, but I'm not sure exactly what's going on with that. Is that a youth panel? Okay. And I don't know how they're going to do that, so I will let you know very soon here.